we can keep that as tight as possible so people can get away on time. Okay, members, so just to welcome everyone here, Linda will be coming. I don't know about if anybody else has given any apologies. We have Danny online. Just to remind members of sensitivity of our microphones, and today's business includes 3 briefings from departmental officials. So the first briefing is on the budget 2024-25 and the main estimates. You'll have received a short briefing paper yesterday. Learning Disability Services and Workforce Policy. And just to the meeting is now open to the public and will be recorded and broadcast through Parliament buildings and online. And I can remind members just to keep all devices muted and in airplane mode. The clerk, you have received apologies from Colin McGrath. Apologies, I hadn't seen that yet. And Danny is online here. And there's no one else other than Linda who'd be coming late. Under Chairperson's business then, I wanted to note that the report for the infected blood inquiry was published on the 20th of May, which is very welcome, and the British Government's announcements around compensation for victims and families. So a very important announcement, and just given that we will have a briefing next week from representatives of the infected and affected community, and with Haemophilia NI and other stakeholder groups briefing the committee next week, and just that we hope, and hopefully we will get clarity between now and then, that given the announcement of the election yesterday, that this will not impact on this legislation and obviously the payments that have been announced and the work that's happening around that. So we hope to get some clarity around that to ensure that there are no unnecessary delays. Members, item number 3 then is the draft minutes. In your pack at page 6 from the meeting on the 16th of May, are members content with the minutes as drafted? Okay, members, I have no matters arising unless anyone else has anything they wish to raise. No. Okay, we'll move straight into the first briefing, and it's the departmental briefing on the budget 2024-25, which has come before the Assembly on Tuesday. Afternoon, you're all very welcome. So in your packs, members, you have the budget briefing paper and estimates and reply to the committee. It's at page 3 of your table papers. We have a briefing paper on the capital budget, which is page 11 of your table papers. The budget paper is page 15 of your table papers, and we also have ministerial correspondence, pages 16 and 19 of your pack, and a Hansard meeting of the meeting on the 2nd of May, which is at page 21. We also have the letter from the committee to the Minister on the 7th of May requesting information on the department's spending plans at page 32. So you're very welcome back. We have Bridget Worth, the Director of Finance, Prada Miller, Capital Investment Director, and Linda Carter, Head of Capital Resources Unit. We have about 45 minutes for this section, so just if you can keep opening remarks or brief. We've obviously had a briefing paper, and then we'll open up for some questions.
Okay.
Thank
you, Chair. I'll start by making a few opening remarks on resource, and then I'll pass over to Prita to take you through the capital position. So as you'll know from your earlier briefing with the Minister, the budget allocation provided for the Department of Health is incredibly challenging. Whilst I absolutely accept that it does represent a significant increase on our baseline position for 2023-24, it does also see a significant reduction in our spending power compared to last year. The opening budget is some 183 million less than the closing position for 23-24 in cash terms, and the real impact once inflation and growth are taken into account will therefore clearly be much more severe. I also accept that the department may receive additional allocations in year. Indeed, we've factored an assumption around this into our financial planning. However, I think we can all agree that the significant increase provided by the financial package is unlikely to be repeated. So the fact remains that even after we factor in £300 million of savings, additional income and additional in-year allocations on top of our £500 million allocation, the department is forecasting a funding gap in the region of £400 million. Broadly, that breaks down into £250 million of a funding shortfall in trusts and £150 million that would be required to provide a 3% pay increase. The department has continued its ongoing programmes to drive efficiency and productivity. Some highlights of this work are provided in the paper in front of you. These are all key contributors to the savings assumptions that are built into the plan. Unfortunately, though, the scale of the gap between our need and the funding available means that efficiencies alone will not be enough to balance the budget this year. The latest step in our financial planning process, as you're aware, was therefore the receipt of break-even plans from trusts on Tuesday evening. These will enable us to determine the extent to which our savings assumptions and therefore our assessment of the funding gap are correct, and will also provide some detailed proposals of the further higher impact measures that are being proposed to bridge the remaining gap. To give you a sense of the work undertaken to get to this point, we first asked trusts to consider a break-even plan based on a flat cash position in December, and these initial plans were submitted in early January to facilitate our engagement with what was initially an NIO-led budget process, with inputs slightly modified to reflect the executive's approach on its restoration in February. It's largely this information that our assessment to date has been based on. So whilst trusts were able to keep developing their plans in the meantime, it's only been since we had an indication of the likely budget outcome in April that we were able to provide them with an indication of the allocation they may actually receive to enable their opening financial position to be finalised. And at that point, they were given around a month to produce their plans, which were received by colleagues in Strategic Planning Performance Group on Tuesday. I'm sure you'll appreciate that despite the opportunity for some preparatory work, this was nevertheless a challenging deadline for trusts to achieve when they are contemplating the scale of deficit I've outlined. Whilst we're all keen to understand the detailed implications of the budget settlement, there was little point in shortening the timeline to the point where the trusts would not have been in a position to have given adequate consideration to the proposals they were bringing forward. We also wanted to allow time for appropriate initial consultation with their boards. The plans that were submitted are now being considered by colleagues across the Strategic Planning and Performance Group, with this analysis involving both the finance team and the various commissioners of service in terms of the impacts that the proposals are likely to have on services. Policy colleagues will also be involved where appropriate. You will appreciate that this is an important step in the process to ensure that trust plans are subject to robust scrutiny before advice is brought to the Minister to enable him to make the difficult decisions that will be required to achieve financial balance. This work is progressing at pace, and I know that the Minister is keen, if possible, to provide you with a high-level analysis of this prior to the debate next week. Indeed, the paper you're looking at today was delayed in the hope that we may have been able to include some material in it. Unfortunately, that has not been possible as the work is at too early a stage at this point. What I have provided in the paper, therefore, is based on the assumptions we've made in providing indicative allocations to all of our ALBs, and those indicative positions are set out in Table 2 of the paper you have in front of you. I've also provided you with a copy of the main estimates. The format of these presents allocations in a slightly different way. The technical detail of that's explained in the paper, but again, they are also necessarily based on the assumptions we've made. This isn't unusual, as we often enter a financial year without all funding allocations finalised, and indeed will need to reallocate funding in year as slippage emerges, new money is received, or priorities change. These changes can then be reflected in the spring supplementary estimates, which form the final position that we will report against at the end of the year. As I said earlier, we will of course provide further information to the committee once it becomes available. I'm due to brief you on June monitoring in a few weeks' time, and this will likely provide you with a better opportunity to receive an oral briefing on the outcome of our analysis of the information received from the trusts. But I'll now pass over to Preeta to provide you with a briefing on the capital position.
Okay, thank you, Bridget. So the Department's capital programme aims to facilitate the delivery of services through the provision of appropriate physical environments. You'll all be aware that the health system requires investment across all areas of the service, but we can only do this if we receive a sustained and significant uplift to our capital budget position. For 24-25, we've received $416.8 million. This will fund flagship projects, contractual commitments, contribute funding to maintaining the estate, including NIFRS and NIAS fleet and estate, our backlog maintenance liability, and allocate funding for pandemic flu, for research and development, leases, and investment in GP practices, all of which we deem to be inescapable. We plan to start 5 new projects in 24-25. These include the new community treatment centre in Newry, the provision of additional bed capacity at Craigavon Hospital, a new interim midwife led unit at Antrim and 2 new ICT projects. These are the GMS ICT and digital dictation and voice recognition, which is linked to Encompass. There's much more we'd like to do right across the health estates, but we're unlikely to receive the funding we require to do all that's necessary at the same time. In addition to the restrictive capital funding envelope, the inherent unpredictability of construction projects has been exacerbated by the current volatility in both supply chains and in market prices of raw materials, all of which has had an impact on how much we can realistically deliver. So with that, Bridget, Linda and I are happy to take any questions that you have.
Thank you, and thank you for keeping your remarks brief, because it is good, and I think we obviously have questions on the papers. I suppose just a couple of things, and obviously we have said, we're disappointed that we haven't been able to get a more detailed spending plan, and Bridget, you've outlined why, so I appreciate that it is very challenging, but it's difficult for us going into a budget debate on Tuesday on how we can scrutinise properly, and we have been asking the Minister repeatedly to provide us with an idea of what his plans are, if he, depending on what money he gets. However, when do you expect to have that? I know you said there the trusts, I think they're due to come back this week.
So they came back on Tuesday evening, and there's a lot of work ongoing at the moment to analyse those. And as I say, the Minister's asked that work be done at pace, because he knows that you do ideally want to receive something in advance of the debate on Tuesday. And if we can give you something before then as a written briefing, then we will. Okay,
no, that's fair enough. Well, hopefully we can or are able to do that. And I understand it's difficult to turn that around, but you'll appreciate the benefit of it for members then going into that debate. In terms of the 200 million savings, are you able to give us a wee bit more detail on that? And I suppose what we really want to know, if you can at this stage, give us an idea of the impact then on service delivery and what that will look like.
So we built 200 million of savings into, it wasn't just savings, that 200 million that we took off the original number to get to the billion was savings and additional income. So around about half of that was actually us saying, look, we know that we normally get allocations in year for immigration health surcharge, and we're expecting some funding from the pharmacy scheme. So that was about half of that. The other 100 million was our assumption around what the trusts might be able to deliver with low and medium impact. Okay, so these are things where we've said they're either going to have low impact on frontline services or a moderate level of impact. So the sorts of things we're talking about there is increased bearing down on agency costs. So, trying to move into that further, looking at locum spending, continued focus on discretionary spend, and, just those general efficiencies. Now, we're not saying they will have no impact, because there's some things where we may be needing to reconfigure services in order to deliver those savings, but broadly, that first 100 million, we believe, is not going to have a high level impact. It's once you get into the savings we would need to deliver to bridge the funding gap that we see those as likely to have a much higher impact. So the stuff in that first 100 million, and I should say again, these are broad assumptions that we've made of things that might be achievable. Those low and medium impact savings, again, will be fleshed out when we actually have had the chance to analyse those trust plans.
Okay, and in terms of reconfiguring services, I'm assuming there's no real plan around that at this stage, or?
No, but I mean, it would be things like, maybe delivering things from one site instead of two sites, so the service still exists, but it's maybe had to be, changed in that kind of way. I mean, obviously something that would lead to more of a reduction in service would be classified more as a high impact. Yeah. So that maybe gives you a sense of, as I say, it's not based on specifics at this point in time.
Okay. Are you able to at this stage, Bridget, give us a bit of a breakdown around funding for elective surgical work and for red flag cancer referrals?
So I can tell you what our assumptions are in the plan. So at the moment our assumption is that we would be able to allocate around about 76 million for red flag and time critical. So that's the figures that we've presented here have assumed that level of allocation. Okay. But obviously when we see the sorts of impacts that might be necessary in terms of what the trust would need to do to bridge the funding gap, we may have to revisit that figure and actually say, well, no, actually the impact of spending less than that may be less. You know, I suppose what we're looking at here is what is the least harmful way of balancing the budget. And so we may have to say, well, actually the things over here that the trusts have put forward are more harmful than a reduced level of spending on waiting lists. So that's the judgment that has yet to be made.
Yeah.
So, you know, we have to make some assumptions to provide indicative allocations to the trust. Those assumptions are not, you know, endorsed by the minister as yet as firm plans. They are planning assumptions.
Okay. And I suppose then, I mean, any funding that was potentially going to target those areas would obviously be targeted at reducing those wait lists. And I suppose the concern is that's probably one of the biggest issues that we have around waiting lists. So if we're not able to do that, or if it's going to be less D for C, then that's actually maybe going to potentially make things worse. Or do you think it would still have a benefit in bringing that down?
So I suppose with the red flag and time critical, it's about, I suppose, making sure that those patients can be seen on a timely basis. So a lot of those patients won't necessarily be on the waiting list yet because, you know, it's in order that we can meet those timeframes. I mean, there has been progress made on the waiting list timelines without additional funding. You know, we have seen a continued sustained reduction, albeit maybe a smaller one than we would like, in waiting lists through a lot of the really good work that's been done by colleagues on the elective care framework and the efficiency drive that's gone on there. So, you know, if that work can continue, you would hope that there might continue to be a continued reduction in waiting lists, but that speed of reduction will not increase without additional investment. It's back to what we can do without additional investment. And as I say, we have seen some really good results in that area from efficiency and productivity work, and that work will continue.
Yeah, okay. And just on the elective surgery then, are you able to give any assumptions around that?
The what I'm talking about, the 76 million would be for
that
red flag and
encompasses
time
that as well.
only.
Okay.
You know, obviously that there is money in baselines that goes on elective work that's outside of that. I don't have those figures to hand,
Okay.
so that will continue. But there will be the budget wouldn't allow us to do any additional investment in waiting list over and above that time critical and red flag.
I suppose tied in with that as well then on waiting lists is obviously workforce and the issues around that. And we have a briefing later on workforce, but is there, in terms of then the funding for the outstanding pay awards, what is just kind of the status around that?
So when you say the outstanding pay awards, I know that there are some in train to be paid in June. So obviously those have been agreed and that money has been committed. So that, you know, that has had to be the first call on our additional allocations. So the funding is in place for those pay awards that have already been agreed in 23-24 and are in the process of being processed through the payroll to payment. Obviously there's challenges around any other pay agreements and as you say, I'm sure workforce colleagues will be able to deal with the specifics of that. And then we have the situation obviously where you know, we are highlighting that the funding gap includes that 150 million around a 24-25 pay award, and it's very difficult to see how a 24-25 pay award would be possible in the current context without additional funding.
My last question just around capital, and I mean I am pleased to see some of the, because two are in my own area around Daisy Hill, the electricity upgrade and the community treatment centre are still going ahead, which is really, really good. From my own perspective. But Prita, can you give us an idea then of the planned capital projects that won't be able to go ahead? Are you able to give us any detail on that?
I mean, the list is very, very long. Do you know what I mean? Like the call on capital really far outweighs what our allocation is. So it's difficult for me to do that.
Yeah.
What it be. So, you know, just to give you a bit of context, this plan was first costed in 2018 at 3.3 billion. It is, as in that's over 10 years, it's now 7 billion. 8.9 billion, Linda tells me, you know, so that is the same suite of projects. And the reality is that whilst in 2018 we thought that suite of projects was deliverable in a 10-year time frame. It's just we keep having to reprioritise and delay projects because the cost of the existing ones just grows so significantly.
Yeah.
And that's probably the biggest challenge we face in relation to capital is the timing of how much we can take forward at the same time.
Okay. Well, maybe when we do have more detail, we can see some of that, just to see what's actually at risk or what's being delayed and what I suppose the long-term effect of that would be. So that's grand. Thank you. I have Orlia.
Yes, thank you. Thanks very much for your briefing. So just to pick up on that again then, on the capital, so I'm assuming then the mother and baby unit isn't included?
It is included.
It
so
is?
yes, the mother and baby unit is still, the business case for that is still going ahead. We have that.
Good. Okay.
Yes, we do.
So out
have
of those
that.
5 that you mentioned then?
As
What-
in,
Start this year.
yeah, because it's not.
Oh,
yes.
okay.
So we're talking about
Sorry.
5 that will actually will start like commencing
Right
to
away,
yes,
well
actually
basically
start-
right away once you just have your budget set.
But the
Okay.
mother and baby unit at about 10 million is still in our plan and still progressing.
Okay.
that is
Preferably
still
maybe in
ahead.
25, 26.
Okay, that's good. I thought whenever you had mentioned the 5 that it was just limited to that. Thank you so much for
No
that.
problem.
And then on the strategies, so is there a breakdown in terms of the mental health strategy? Siobhan O'Neill gave us a brief the other week. Now I'm conscious that obviously the total amount of that is huge, you know, what's
On the
required.
revenue
Yeah.
side.
Yeah. So but they were saying that or Siobhan O'Neill was saying up until now it's only received a fifth of the required investment. Is there a set budget for what it's going to receive this year?
So
Bridget?
there will be no additional funding.
Okay, so
Available
that'll be an
this
if
year.
then. That
Yeah, I mean,
that's the way
and
they
that's,
worked it out.
unfortunately, that's the position we're in. You know, we're
Yes.
actually looking at having to make reductions. So
Yep.
what we've tried to do with all the strategies is where activity was put on the ground last year, and maybe if it started mid-year,
Would continue.
that it would continue.
But
So there's,
nothing
you know,
over
for
and
example,
above
the
that?
cancer strategy
Yep.
is getting an additional 2.3 million, but that's just to enable us to continue stuff that started in 23-24, but
Okay.
had, you know, didn't start at the start of the year, so had a tail into 24-25. But in general, you know, the budget just doesn't enable us to do new investment.
And does the same go for Protect Life and the substance use?
The same would be true.
So
for
right
those.
across
So
all the
if-
strategies basically?
Yes, so anything that's currently happening
Mhm.
is being funded to continue, but we haven't been in a position to give additional allocations to enable further activity to start.
Okay, and then just on the trust budgets, because again I'm
I
conscious
should say that's based on our current planning assumptions.
Yes, of course.
Just please
Um,
take that as read.
Yes. So the trust budgets then, so you don't have that breakdown yet. You're still unpicking some of that. I'm just conscious then of a lot of the mental health initiatives that are run through the trust areas that might, you know, there's some really good pilots that obviously might be cut now if the trusts are facing, you know, if their budgets are so tight. Can you share with us in terms of any of that information, in terms of, you know, do we know what is potentially being cut or how much is potentially being cut from trust services?
So at the moment, as I say, that 250 million was our forecast of what trusts may need to do in terms of higher impact measures, whether you call them savings, whether you call them cuts.
Mm-hmm.
Obviously, we hope that maybe the trusts have identified more low and medium impact savings that can be done, so that 250 million might come down. And we have had some early indications that it may come down closer to the 200 million mark, but we are still looking at around about 200 million of high impact savings, would be my guesstimate at this point in time until we see the detail. But I can't be specific as to what that might be. I mean, I think in the Minister's previous letter, he'd given you sort of here's a package of things that would be £100 million worth of savings and reductions, but we really need to see what the trusts are bringing forward.
Okay, and then my final question is just around, so in terms of, you know, what services or projects will potentially be lost or not be able to be funded within this this current budget. Is the department undertaking any engagement at this stage, or any planned engagement for groups and individuals who's going to be impacted by this? And I'm thinking about, even obviously patients first and foremost, but the community and voluntary sector who would be involved in potentially a lot of this work that might be cut. Is there any conversations or engagement ongoing around?
Not yet,
Okay.
because we're waiting to, so I suppose the next step is for us to do that assessment and for, recommendations to go forward to the Minister, and then for decisions to be taken. But, there will need to be engagement at that point, obviously around, well, if these are the things we think are least harmful, how can we implement them in the least harmful way, and with that further involvement. I mean, having said that, we are, we're in May, so we will need to move at pace in order that we don't have to cut deeper, because obviously the longer you leave it before you stop spending, the more you have to do in order to fill the same gap. So whilst we will want to be as consultative as we can, and indeed obviously where there's a statutory duty to do so, we will need to do that, but we will have to think about how and what we might be able to do as quickly as possible in order that we mitigate against having to cut deeper, because the sooner you cut, the shallower the cut can be.
Okay, Nuala?
Thank you very much for those answers. I had a lot of similar questions, so most of mine will be just kind of following on from those questions. I recognise obviously that we don't have all of the detail, but I still think that there's scope here for enough discussion around these, and I do recognise the difficult situation that all of the departments of the executive are in, and there was no opportunity at any point that any single department would get the entirety of a budget. It's unrealistic, so it is unfortunate, but it's the circumstances that we find ourselves in. But I do want to follow on from something that you did say, Brigitte, about the trusts and bridging that funding gap. And also you'd mentioned then later on, just a few moments ago, about the Minister outlining the 100 million and what that impact could be, as an example. But I just wanted some clarity in terms of the decision-making process around the impact. Are we expecting the chief execs of the trusts to come up with the areas in which they believe could be the money saving and would have the lowest impact in terms of health outcomes? Or are we also taking it at looking at the biggest opportunities as well? Because sometimes they don't always measure up, but also then at what stage then is the kind of department come in? I'm just conscious that the trusts are all in each trust area. It's not a single trust, and there'll be different things then in different trusts that they will come up with. So how does it land in terms of the overall decision making, so that it doesn't kind of solely fall on the shoulders of those the chief exec of the trusts, but also not exacerbate the postcode lottery, given the circumstances that we are in?
Okay, I'll try and unpick some of that, and if I miss anything, I'm sure you can.
I know it was big, sorry. But
No. Well, like I say, I'll do my best, but do feel free, if I miss something, just let me know. So there will be different opportunities available to different trusts. Some trusts will have more scope to save in some areas than others. So I think it's right that the starting point is the trusts individually looking at it. But like I say, that's why, we haven't just taken what the trusts have given us and said, here you are, this is the plan. That's why we're now going through this process of scrutiny, and colleagues in strategic planning and performance group, not just finance people, but the commissioners are looking at this, and they will be challenging, well, is this really the best, the least harm option, or the best you can do in this area? And like you say, they will be looking at, we know the trusts work closely together, and we welcome the fact that a lot of their plans, you can see the collaboration in the plans when they come forward, and that is to be welcomed. But the commissioners are there, and our colleagues in Strategic Planning Performance Group Finance will be looking across them to make sure that all of the trusts, if they're saying we're making a saving in this kind of thing, well, if that trust can do that, why can't that trust do this? Or, and that sort of landscape piece, and that is why we just need a bit of time before we would come out and say this is what the position is, because as you say, it's important that there's a degree of consistency in the sense that in the way that it makes sense. Every trust is different, so every trust will have nuances, but our aim would be that the impact is similar across all of them, and indeed, they will be looking at the impact on individual services on a Northern Ireland-wide basis, but also the combined impact on a single trust geographical area of the proposals.
I think that's helpful, especially in terms of the collaboration element across the trusts, because that's one thing that I was wanting in that question to get to the bottom of is we know that, well, most of us recognise that not every service should run out of every single trust, that it should be Northern Ireland wide, no matter where you are. But will there be that kind of collaboration once this is made, that if there is a cut to a particular service, that there can be transfers that don't necessarily mean more spend, but actually it means that if you're on a waiting list in one trust for something that is quite specific to a service that is run in all the trusts versus services, I don't think I'm making myself clear on that, but if it's not just simply shifting the burden, it's about sharing it so that it's more efficient across the trusts. I know that reconfiguration is one element, but that's not happening right now because it just can't, and for other reasons, and we don't have the blueprint yet, etc. But where we can in the short term, will that be happening?
I think the short answer is yes. And that's, as I say, that's the purpose of that landscape review being undertaken. It's hard to know without having specifics exactly what the opportunities might be. But I think the waiting lists are already managed on a sort of Northern Ireland-wide basis to a degree. So, the overarching aim of what we're trying to do here is to come up with a plan that breaks even with the least harm. So that is what's underpinning all of our considerations in what we're trying to do. So absolutely, if there's a way of collaborating to ensure that whilst the service might contract, that there's still accessibility, I'm sure those options will be explored.
And one of those might be, for an example, like respite services, for an example that isn't shared across trusts whenever some do have capacity and others don't, and the funding model is still there regardless of whether the capacity is at its max or not. Might something like that be looked at in terms of maximising what we're actually doing for our spend?
I can't get into that level of specific.
But it's because you asked for an example. Or
I'm not at that level of specific. But all I can say is, I'm sure, given the position that we're in, that no stone is going unturned.
Well, thank you. I recognise. It's difficult to ask more questions when we don't have the detail, and we will have to wait for more. But thank you,
Diane.
Yeah, thank you. Can I just ask a quick question on why was the digital dictation and voice recognition, I'm presuming linked to Encompass, not included in the procurement in the first instance? Surely that's a fairly standard part of what you would want to do.
I'm sorry, I'm not 100% sure why. I'm not sure why it wasn't included in the procurement.
I think basically this is for sort of senior consultants and things like that, and so it was something that was recognised after the Encompass business case was completed.
It's basically taking their existing digital dictation systems that are coming to the end of their lives and trying to replace them with a single solution that means that the electronic records can be updated in a more efficient way, and they basically think this will have create efficiencies in service provision as it's rolled out and implemented.
Just that I may be completely at the wrong end of the stick, so like that, and knowing my technical Counties, that's
I
probably
think-
that. But it just seems strange to me because we did have, and I asked very specifically, one of the reasons one of the consultants that was here gave for the problems with Encompass was that it added about 13 to 15 minutes to every consultation because they then had to upload all of the information. I was presuming that if we were going to a digitised system, that digital dictation and voice recognition would be part of that procurement process in the first instance and not added afterwards. And I would just want to know at what additional cost that has come.
Yeah, it's an additional cost of 2 million. Yeah.
So it's an additional cost of 2 million in every trust or
No,
across
that's
the
the total
board?
cost of it's 2 million. Yeah. the total.
And that will be it.
That'll be
it won't
it.
happen.
Well, I
The
can't
Belfast
guarantee
Trust won't have to have it.
That's
They will all.
that's the bid for the total solution. So that's an extra 2 million. But I think part of this is because there are other IT systems in trusts that as they come to an end of life, they're having to replace those functionalities, but Encompass provides an opportunity to maybe find a more efficient solution. So my understanding is once this is done, it'll take some of that time away in terms of recording the information. It's designed basically to lead to hopefully efficiencies in the service.
Yeah, I'm still not sure why it couldn't have been done at the start, and whether that has actually cost us an additional amount of money. And I suppose that's where we're in problem. I do think it's a pity that we don't have more information in terms of the budget. I do understand why, and I do think it's a pity because when we look at some of the really important big issues that we have to deal with, only having the information to break that down for this committee is going to be going to be useful. But a colleague who was at the Finance Committee yesterday was telling me that finance officials indicated that in the June monitoring round there'd be an additional 247 million for reallocation. Now I have no doubt that every minister will have a request in, and that's part of the course, and we understand that. But I would like to know if Health are going to bid for some of that, and if so, what are you going to bid for? Because I think one of the frustrations with Health, and one of the frustrations for those of us who are looking in on the budget but not intimately involved with the budget, is that we see this as going into a black hole, and that money is just simply plugged into gaps, but we're not being specific about the purposes for it. So has there been any discussion on what those potential bids would be? And can people listening to this who are involved with the stroke strategy, where we haven't really actually seen any outcomes to the strategy, really will they see an improvement from the bids that are to be made?
So, as I've said, we're currently forecasting that £400 million funding gap. We've also assumed in arriving at that funding gap that we would receive 75 million in year from in-year monitoring rounds. So my recommendation to the Minister, which he may or may not choose to accept, would be that we at a minimum would bid for the funding to plug that gap and for that 75 million. What we want to be able to do when we come to submit the bid is to articulate the impacts that receiving the funding would mitigate against. So when we have a detailed plan as to what would be needed to do by the trusts to plug their shortfall, when they tell us, right, these are the actions we're going to need to take to plug the shortfall, then we will be saying, well, if you were to give us that extra 250 in monitoring, these are the impacts that could be prevented. So what we're talking about is asking for the money to prevent us from having to make reductions. And then potentially, if there's only 247 million available, it's probably only going to go to plugging those reductions. You know, the pay issue then is on top of that.
Okay.
But I mean, my recommendation.
So what you've indicated to me are two things, really, Bridget. One is that we need to see some detailed plans around this, because most people looking at this see that health gets almost 52% of the budget. You already have almost 50% of any of the additional funding that was available from the original budget, and I understand the difficulties. And we're taking those difficulties as being there, and we understand those, but we also need to understand that it is simply not going to plug gaps, and that we will be able to, at some stage, to see additional activity on waiting lists on cancer services, on stroke services, because that's what people really need to see. And I do think, I'm just coming back, the short of it is, the planning around this is massively important.
No, appreciate that, and as I say, we are doing everything we can to work at pace, but against that, you know, it's just unfortunate that the timelines have been truncated this year, and we're doing what we can within the time available to us, but at the same time, we have to balance the speed with the need to try and get it as right as we can.
So just finally, Chair, in relation to this, so for example, if you are trying to reduce costs, say for agency costs for nursing, are you also trying and in asking trusts for targets in relation to locum costs? Because that's what I understand are the highest costs.
Absolutely, and I mean, locum costs is one of the things we've identified as something that really needs to be targeted hard this year in order to mitigate those. You know, we've had a lot of success with the work that's been done on nursing, and that was the biggest cost, you know, the biggest absolute cost. But as you say, the locum premiums are absolutely very high on our list of things we definitely need to tackle, but that will only go so far into the gap, and as I say, that's already sort of planned in with those levels of savings we will already anticipate, although we hope, as I say, that 250 number might get smaller with the plans that are coming in now. But as I say, between that 200, 250 and the 75 million we've assumed we might get in year, you know, it's a choice then between, okay, well, are we prepared to take, and I appreciate you know, none of us have seen the potential impacts of those cuts. I mean, it will absolutely be a valid choice for the minister to say, well, actually, I'm happy for that service to be cut in order that I can invest in something else. That will be something that the minister could decide to do. But I suppose my sense at the moment is the need to protect existing services is obviously significant as well.
Yeah,
Right, sorry, can I just say, and I know this isn't your bailiwick, I do think that bearing down on agency or locum costs is important, but the other element that we're going to come to about safe staffing is massively important as well.
And I think
and
I think you're recognising the tension between those two things. So
I'm going to have to move on because we've 3 members left and we've just 10 minutes. So I have Linda, then Danny, then Alan Chambers.
Thank you. Excuse me, and I apologise that I was late, so I may have missed some stuff, but I just had one question because everything else that I had in my head has been covered. So, and it's just around the recommendations in the Ray Jones report around children's services. Has there been any conversation at all around budget or money or financing any of those recommendations? Has it come into the equation at all in terms of conversations with the minister or with yourselves?
So as I say, really it is that difficulty of being able to fund anything new. I mean, having said that, my experience, and I'm not across the detail of that report, but there are usually some things that can be done without significant additional investment, and I'm sure that colleagues in that area will be focusing on trying to identify what those are and progressing those, even if we're not able to provide additional funding where that's needed. But I'm not fully sighted on that.
No, and I think that's fair. I'm going to take from that there's been no specific conversation around it, and I'm asking the question because some of these recommendations, whilst new, would be replacing what is already there that's not working. So it's investing better rather than investing more. So investing differently. So have there been any conversations that you're aware of?
I mean, I suppose I am
specifically with yourself. I understand you can't.
I generally have those conversations with all my colleagues about the fact, and to be fair, you know, I'm teaching my granny to suck eggs a lot of the time when I'm having these conversations with my colleagues, but you know, it is that emphasis that actually there are some things that we can do to transform services within the existing funding envelope that we've got. I mean, as Diane pointed out, we have got 50% of the budget, so there is a lot that we can do with the money that we have. And you know, I pointed out there's been a lot of progress made in terms of turning the corner a little bit on waiting lists without additional investment through productivity initiatives, efficiency initiatives. So I'm sure if there are things in that report where you could use the money we have differently, that those will be things that will be looked at, and there's no reason that they can't go ahead.
I think it goes back to the point that's been made and the point that we're making every week, and this is not for yourselves. It is what is the departmental plan, the minister's plan, what are the priorities, and we don't know.
Danny?
That's not your fault.
Thank you, Chair. Can you hear us okay?
Yep.
Apologies for not being there in person. Thank you for your answers so far. I think I know time's tight, so I'll be quick. I have a couple of points I want to make. The first one, now we've heard this mentioned a couple of times, and I just want to confirm for healthcare workers that the pay award will be paid in June. And the three elements of the pay award are the 5% uplift, which will be backdated to April 2023, and then 5% going forward, and a one-off payment of £1,505. I understand, although I appreciate this isn't agreed by all unions. Is that confirmed going out in the June pay packets now?
So that's my understanding, but I know you've got workforce colleagues up later this afternoon. They will be better placed to confirm that plan is still on track.
Okay. You mentioned that was working its way through pay packets. That is the case, that's your understanding?
That's my understanding, but as I say, I know my workforce colleagues will be more on top of that than me. But yes, there is no funding impediment to that going ahead.
Okay, thank you. Like other members, I do look forward to seeing more detail before Tuesday's debate, and I hope that you're able to furnish us with some papers that will help us prepare for the debate on Tuesday. One element that I'd be really interested in to see is the reconfiguration blueprint. I'm just wondering, will this be available before the debate?
I don't know. I know that work is ongoing and is in an advanced stage, but I can't. I don't know whether it will be available before then or not. I'm sorry.
Okay, and just I'd like to talk about some long-term cost savings as well, and in particular, Diane had mentioned this earlier, just about the stroke action plan. We know obviously the stroke action plan is being progressed and it is subject to budgetary pressures. But we know that it will, in the long term, save money. Thrombectomy saves a lot of money. It's 100% cost effective. Each patient who receives thrombectomy saves the department £47,000 over 5 years. And obviously the patient, there's a huge reduction in suffering, a huge reduction in disablement, and a reduction in the need for post-stroke rehab. So I'm just wondering how much of the stroke action plan, and particularly the move to 24/7 thrombectomy services, are going to be part of this. Do you have any detail at all over that?
So, I mean, as I said, currently the plan does not allow for additional investment in services over and above what's currently in the baseline. We're looking at what we're going to have to take out of services in order to manage to break even. So obviously if we want to introduce something new, we would have to cut further in to existing services in order to be able to afford that. And I think, you know, one of the hard things at the moment is, you know, knowing that there are areas that if we could invest, I mean, training is a typical example. If we have more money to invest in training, we know that that will help us in the longer term with things like locum costs and agency costs. But at the same time, if we don't have the money now, and we're having to balance that against cutting existing services. So that is the issue that we have. We know there are things where if we spent more money now, they would help us to save money into the future. But if we don't have the money now, it's just a very difficult situation.
We do know that the Finance Minister had mentioned that she is opening a £47 million per year transformation fund over the next 5 years, and I would hope that obviously bids are being made for such long-term cost-saving projects to be part of that transformation, and I do look forward to hearing about some of that. My last question, I just wanted to talk, you had mentioned that there was success on the cost of nursing. You were talking about locums and agencies at the time. Now, my understanding is that the change has been off-book agency has been stopped. I'm just wondering how much has been saved by that one change, and if you can give us a ballpark on this, how much would be saved if we were able to move all agency nurses onto trust banks?
So I don't have exact figures on that second part. I know we're expecting agency costs to come down by around about 20 million in 23-24 as a result of both the nursing framework and the work that's been done with social work. Now, that is net of some increases we've seen in other areas, so the actual impact of those reductions is more significant than 20 million, and we would hope, obviously, that new framework was introduced mid-year last year, so we would hope that the full year impact of that would be greater. I think the difficulty is, and I can't remember off the top of my head, I'll probably have in my briefing somewhere how much we've spent on agency, but the saving really is around the premium on agency. So as you say, it's not that we are in a situation where we need somebody to fill the post, but if we could fill the post with somebody who's been paid a trust rate instead of an agency rate, we would save. So it's around about the 10%. Well, it depends on the premium that we're paying. But if you said it was a further 10% on what we're expecting to spend this year, it would be another. I've just found my figures. The projection for this year's spend on agency in total is 373 million. I think that includes locums as well. So I mean, there is a big number there for us to go after.
Mm-hmm. Absolutely, and thank you very much.
Thanks, Danny. And Alan Chambers.
Thanks very much, Chair. Bridget, earlier there when we were talking about the budget lines coming from trusts and choices having to be made, you used the terminology least harmful. That's how the choice would be made, what was the least harmful. But when we're using the word harm, that implies that there is a potential for harm. So is that correct? Would it be, if some of these cuts are made, even if they are the least harmful, do they still carry the potential to cause harm to patient care? So,
I mean, the advice I'm getting from trust colleagues is that to cut as much as we expect to have to cut this year in order to break even would not be possible without at least the potential for some harm.
Yeah. So I think we should put that on the record, that those cuts do have the potential to cause patient harm. In terms of pay awards, I don't want to sort of compromise too much the junior doctors dispute at the moment, but we've heard that one of the solutions might be to, part of the solution might be to offer annual sort of incremental commitments of salary. In the absence of a multi-year budget, would those commitments be getting given at risk?
So, I mean, it would obviously be a decision for the Minister as to whether they were prepared to make commitments at risk, but my advice generally as Finance Director would be that would be unwise, that it would be difficult, and that potentially you're then, when you don't see the full picture, I think it's hard to make those sorts of judgments in advance. But clearly a Minister would be liberty to override my advice
A
if they
dangerous road to
chose.
go down, nonetheless. Yeah. Just in relation to, I agree totally with colleagues here saying we need to see more detailed plans, and as Diana said, massively important that we see the big picture. I would just say that what's going to come from the June monitoring round to health is going to be vitally important, and there is a potential that there will be an amendment on the floor on Tuesday to delay the final signing off of the budget, and it might be something that members might be worth considering. If we want more information, a couple of weeks delay would certainly facilitate that. Thank you.
Thank you for coming in, and I suppose I know it's a difficult situation, but if possible, if we can get whatever information is available ahead of Tuesday particularly, I think it would be really useful if we can, and I'm sure then we'll see you back at committee at some stage then, maybe to look at that in greater detail. But thank you all for your time this afternoon. Okay.
Thanks very much.
Okay, members, thank you all, and I suppose we have, there's a lot to think about there, but hopefully we will have more detail, and maybe by this time next week we will be able to ask some further questions on that. And we can write to the Minister then just around getting further detail on the spending plans if members are in agreement to do that. Okay, item number 6 then is the next departmental briefing. It's on learning disability services, and it's at page 34 of your pack. Hello, how are you? Thanks. You're all very welcome. Thank you for your time today. So just in attendance today we have Nigel Chambers, Head of Learning Disability and Autism, David Pettigrew, Deputy Director of Community Care, Learning Disability and Adult Safeguarding, Ciara McKillop, Deputy Director of Community Care for Mental Health and Children, and Maurice Leeson, Programme Manager, Partnerships, Emotional Health and Wellbeing, Child and Adolescent Mental Health and Disability. So thank you all for coming. We have about 45 minutes in total for the session. So if you're able to keep the opening remarks brief, because I know we have a very good briefing paper here as well. So thank you, and then I'll open up for questions. Go on ahead.
Thank you. Good afternoon, Chair, and thank you for the opportunity to provide the committee with an update on our work to improve services and transitions for people with learning disabilities. And today we would like to provide you an overview of the challenges across health and social care, the work underway to address these challenges, and to give you an overview of the direction of travel. And in terms of your written briefing, there is an emphasis on adult learning disability services, but we would also like to provide an overview of our work to support children with disabilities, as both work streams are being progressed through the lens of transitions. And while these represent distinct and separate health and social care services, we must be cognizant that the level of need presented in adult services can be partly traced back to how well we support people as children. So, in terms of your briefing, you will note that there's several long-standing challenges which are cross-cutting in terms of professional, agency and departmental boundaries. People with learning disabilities will experience entrenched physical and mental health inequalities, and these are compounded by lacking access to both primary and secondary care, as well as limited access to community mental health services bespoke to their needs. Day services and short breaks are stretched significantly to meet the current level of need within the system, and the conclusion of the European Social Fund significantly impacted the delivery of community-based day opportunities. There is lacking access to housing, and that in turn can create increased demand for social care. In terms of children's services, there's been growth in both the population and complexity of need for children with disabilities, and that has stretched social care significantly, but also there has been a correlating increase in terms of the children with special educational needs, which has significantly stretched our healthcare provision across schools. Lastly, in terms of challenges, transitions are a long-standing policy challenge, as they are ultimately dependent on the availability of services and effective interagency working. So in terms of what we've been doing about it, in March 2023 we established a Learning Disability Task and Finish Group. It set out to finalise our service model for learning disability, to finalise our Children with Disabilities framework, to develop an overarching governance structure which will oversee the implementation of both products, and to progress a review of evidence, research and data. And in the past year, significant progress has been made to better understand our population, the presenting level of need, our capacity to meet that need, and to identify the way forward to support those needs. And the paper that you have been provided sets out the work that has been completed to date or is nearing completion. Throughout all of this then, engagement and cross-departmental working to date has been extensive. Officials have utilised a range of cross-departmental structures and initiatives to ensure that opportunities are maximised for public services to be delivered more effectively. We have and we will continue to engage families and people supported by our services to guide the way forward. In terms of direction of travel then, a draft model has been developed and shared with our range of stakeholders, which sets out a regionally consistent approach to service provision. It also outlines the work that the department will progress to make this a reality. And in terms of what it sets out, it is a progressing transition through a lifelong approach, expanding health and well-being measures and supports to address entrenched health inequalities, to improve and diversify the level of support for carers and families, to promote meaningful lives and citizenship through the expansion of community-based day opportunities, to better support people to live in their own homes and improve our interface with housing, and to improve mental health outcomes and address behaviours of concern. And right now work is underway to develop that model further through a costed implementation plan, and a draft has already been shared with the independent sector and trusts for comment. In terms of children with disabilities, the framework has been updated to better connect with special educational needs services and healthcare. And throughout this work, we have remained cognizant that how we support children at home will impact their ability to access the curriculum, but equally, how well we support children at home, or at school, will impact their presentation at home. And to date already, a number of recommendations from this work have already been progressed through the Children's Social Care Services Strategic Reform Programme. And these include a demand and capacity review for short breaks, a review of early intervention and community-based supports has already been completed. We are currently exploring options to recruit and retain foster carers to improve our offer of short breaks, but also residential placements. A regional consistency review of children's disability services has been completed. And finally, a draft model for children adolescent mental health services for those with learning disabilities has been developed. So in conclusion, we fully recognise the scale of the challenges across services for people with learning disabilities, both children and adults, and the need for collaborative working. We are hopeful that the work set out in the paper and through our contributions today will provide you assurance that we intend to meet this challenge through the lens of evidence, research and data. But as we move forward, it is also critical that we are guided by those that use our services and those that deliver our services. Thank you.
Thank you very much, Nigel. And I mean, the briefing paper has been very good, so we really appreciate that in advance of the meeting. I just have a couple of questions, but I suppose the first one really for me, you've mentioned that the consultation is obviously underway, and I appreciate we've just had a briefing on relatively limited on the budget, but I suppose when do you think, all being well, that is likely then to be the actual implementation of the service model could begin post consultation? And have you had any conversations with your colleagues in the finance department within the Department of Health around what that's going to look like given the current projections, or is that still something that's being discussed?
Okay, well, to answer your question directly, we're aiming to go out for public consultation on the learning disability service model this summer, all things being equal. At the moment, there is the implementation plan is being developed, and a costings exercise will still be needed as part of that process. Once we get an understanding of what costings are needed to implement the service model, we would then be in a position then to approach the Department of Finance. Taking into account then a public consultation, analysis, and where we were going for early, I suppose, implementation, if we go out at the summer, Christmas for analysis, implementation or decision for an implementation, you would say still within this financial year?
Okay, that's quite positive. Sometimes it's nearly way down the line, so it's not too often that we, and I know there's a lot of things at play here, particularly finance. But hopefully by then we'll be in a different position. We'll potentially have a different government across the water, which may impact on things too. So that, hopefully if things stay on track, that will be good news. And I think, given the level of detail that's been provided here, I'd say all members around this table have had experience of dealing with constituents and in personal capacity of the real challenges facing both children and adults in terms of learning disabilities and families. So I think on reading it, it does reflect a lot of what we're hearing on the ground, which is really good that that's been picked up on and that the department have recognised and are hearing that, and that then anything going forward will be evidence based around that. So I think that's positive. I suppose just then on the back of that, transitions, and I see that you've particularly outlined that, and I think it said that the approach that will be finalised in the coming weeks. So just a wee bit of detail around what are the next steps in that, and I suppose why I'm asking that particularly, and I'm going back just to some issues I've been dealing with my own constituency. We have Windsor Day Centre there, and some of the respite at Carrickmore and others. Given the level of transitions that will be required, you mentioned, Nigel, about the community-based day opportunities. So yesterday I met with Bolster, who are very, very embedded in our community, locally provide excellent opportunities for young people and adults with learning disabilities. I actually was speaking to one young fella who's engaged with their service, who previously probably would never have been on the cards for him to live independently, but given the work he's done through there and how it's brought him on, he's now going to live independently. So really, really good success stories through the community voluntary sector. When you talk about community based, is that part of that work in terms of the community voluntary sector organisations and that, and will work around transitions then be matched with increasing the provision, so not just for day opportunities but for respite as well and things like that, where it's particularly where young people are coming out of school and parents are then, I know I mentioned Windsor Day Centre, I'm dealing with families who have young people who are very, very complex, who would need full time, say 5 days a week, but are potentially being offered 3 and are heading into a crisis. So I know there's probably a whole lot in the one there, but kind of you get the overarching question I'm asking is around the work on transitions, what the next steps will be, and what that will look like in terms of matching that with the provision to meet those needs.
Well, I'll give you probably just a bit of an overview around the day opportunities piece, how that feeds into transitions, and pass to Morris about how we're intending to kind of operationalise our approach to transitions. So, I suppose one of the most significant challenges around effective transitions management is actually ensuring that there's good services waiting for the person when they turn 18. And it's important to remember that actually becoming an adult is one transition in a person's life. And as a person navigates a number of transitions throughout their life, about entering employment, finding their own home, meeting somebody, starting a family, all of those sorts of things, that the principles of good transitions management are just as applicable then as what they were when they were 18. And through the model that we have developed, we have really adhered to NICE guidelines to ensure that we set out the correct process. What that looks like, quite briefly, is ensuring that there is sufficient access to information and support at an early stage. So part of good transitions management is understanding what's available to me. And part of that is building up a menu of services. Then I suppose it's adopting a very person-centred approach to transitions and ensuring that there's sufficient choice and control throughout the planning process. We're not fitting people to services. We're providing people meaningful choice and control about what their life looks like after school and the role of health and social care in that space. Within that then, we have to draw in multidisciplinary input, and typically within learning disability, conversations shift immediately to social care. What day centre are they going to go to, what level of short breaks is going to be provided for the family. And yes, to be honest, in terms of the type of service that will be provided, that will probably make up the bulk of the care package, but we need to draw in healthcare professionals as well people and children with learning disabilities will have a higher level of comorbidities than general population, and poor management of those healthcare needs can constrain a person's transition choice. If we don't manage things like epilepsy and diabetes well in the community, then that limits your transition to a day centre. So day opportunities potentially fall off the table. So it's ensuring that we have healthcare professionals around the table when it comes to that planning process. The other key pieces then are ensuring that actually somebody takes ownership of this. We've already begun a costing exercise to ensure that each trust has transition workers. So this is somebody that can support the person, help them navigate our health and social care system, but also negotiate and advocate on their behalf. They don't sit outside the system, they sit within the system. There's other pieces that we need to do at a departmental level to kind of get to that place of really good choice and control throughout transitions, because we can define the health and social care service. We can expand day services, we can expand short breaks, but things like supported employment, volunteering, further education, and access to housing, we've set out a body of work within our model that brings those partners together to say, right, how can we start to pull our services and commission them together to ensure that somebody has the same life choices that we all did when we became adults. So that's the aim and the aspiration. What's needed to achieve that is good cross-departmental working, good interagency working. Data is a huge piece as well. We have a system that acts surprise when people turn 18. We need to ensure that data flows from early childhood throughout adulthood, so we can, unless we know who's coming through the system, we will never have the sufficient level of services waiting for them when they become 18. So good data throughout transitions right into old age is important as well. That probably covers a lot of what you were asking about. In terms of day opportunities, just to be very brief, it would be the community and voluntary sector that would have a leading role in this. They have already had a leading role in terms of the expansion of the model since 2014. That was partly, the European Social Fund was a catalyst to that, but the evidence is clear. Community-based day opportunities offer superior quality of life outcomes and value for money. It's a better service. However, we do recognise that for some individuals, daycare is still the best type of service and support. So we need to modernise what we keep. I'll pass over to you in terms of the
Just in terms
protocol.
of the children's and the protocol, we've had 4 regional workshops to develop a new approach to transitions, 3 of them in person, 1 virtual. It was part of the Children's Disability Framework. We were very conscious of the fact that for parents this was both a very stressful and challenging time, and recognised a lot of improvement needed to be done there. As Nigel has said, we have finalised our draft. We're looking at developing an easy read version to help us really with sharing and getting responses to that. The data template's an important part of it because, again, as Nigel has said, we have to have better information to know both when children are coming forward for transitions from a very early age, from 14, because there'll be some children whose complex needs actually it does take quite a number of years to put in place the arrangements that they need, and if it's left till 18, then there is little chance of that happening effectively. And we've had a very, very good response to the development of this protocol. And I think probably what we did this time, which we haven't done before, we've tried before for children's services to work out how best to do transitions, and we've tried then adult services to work out how best. This time we've done it collaboratively and produced a model which I'm very pleased with, and I think is going to be a good basis for us moving forward.
Yeah, no, thank you. But I mean, sorry, David. Did you
I'm just going to say something from an adult services perspective, because I mean, obviously that's a key service area as well. I mean, over the years, a number of things are fundamentally true, which is good transition planning starts early. I think it's as points been made, it's a real pressure point for families, a source of anxiety, and I think that cliff edge, which can happen as young people and children transition into adult service, is really important. It's a different type of service response for adults with learning disability than it will be for children with disability, and that transition period is really important. People should be able to try different things, see if it meets their needs, and I think for families and for the young person themselves, it's a really potentially very anxiety-provoking time. The range of services are different for adult services. Some families can be challenged by that, but an over 18-year-old has a different range of rights, a different range of things that they will want to do, that a child with disability will see that in a different way. But the other thing to say is that there's really good practice in trusts at the moment, just to acknowledge that. But standardising that good practice across the region is really important. So we're not starting from zero on this.
Yeah.
I think there's still scope for improvement.
Yeah, no, I think those points are really important, David, because there is really good practice happening, and it's about pooling that good practice and experience together. The biggest issue for me is certainly it's the resource, and that's where the problem lies. And we're dealing with a situation where we have more and more young people coming through with more complex needs, and we just don't have the capacity at the minute. But hopefully, I mean, I'm certainly very heartened by what I'm hearing, and I think it's really, really in tune with what we're hearing on the ground from families as well. So hopefully, and certainly I would say most members around this table will be supportive of trying to move that forward, you know, in the time ahead. So thank you for answering those questions. I have Linda very quickly, or first, sorry, I'm going to just pop out 2 seconds.
And some of what I was going to ask has been addressed, so I'm not going to put you back over that. It has also created, I suppose, some questions for me. I suppose the first thing I want to get an understanding of, I mean, when you're talking about, and Nigel, you'll know from previous conversations that there have been some challenges in my area in the Southern Trust around transitions from children's services to adult, particularly where you're talking about where there's full-time care required, and where that then has had a knock-on effect for respite and for families and everything else. That creates an awful lot of anxiety, and I know you are well aware of that. I think for me then the important bit is getting an understanding of how we are going to create equity regionally, so ensuring that right across the board, and that there's learning from what works, what doesn't work, what is good, you know, and let's roll this out, make sure it works for everybody. And I think we haven't done enough of that in the past, and if we're getting to that place, that's great. So I'm looking forward to seeing what is actually in the consultation as well. But for me, that's really important, you know. So first of all, are there individualised transition plans? So, you know, are there standardised guidelines for creating those plans and for moving from children's to adults, and how are they monitored and evaluated? So you're saying from 14 you need to be looking at, and I understand that, but we all know that a lot can change between 14 and moving into, so yes, at 14 we should have at least a good understanding of the complexity, whether this young person is likely to need full-time residential, or whether it's going to be respite, whether they're going to be able for day services, all of that. So, but how do we monitor? Are there individualised plans, and how do we monitor and evaluate that? I suppose it's the first. I don't want to ask anything that's complex enough in itself.
Okay, in terms of the 14 is the very critical point, and I do take your point that things do change, which is why it's important really to keep an eye on the transition from 14 onwards. Plans are put in place, and one of the things we've recognised in our work at the moment is that we need to improve our monitoring of that. So we have actually set in place a data return which will enable us to get a better sense of how many children are coming forward from 14, 15, 16. So we know in advance how many we're talking, but we know in advance where there are complex issues that are going to emerge, and these could be complex issues that require, for example, input from housing, input from different providers. So the key to it for us is, as you say, is to keep that monitoring very effective and to make sure we have the information to be able to do that, and where there are problems and where there are issues emerging that require, for example, a direct departmental input, that we can recognise that and get involved ourselves.
Okay. How do we overcome that? So if you know what the problems are, have you an idea of how you're going to address it?
Yes, I mean that's sorry why we were saying with the apologies. Sorry, why we were saying with the actual
hearing. So apologies, I don't. It's not great. My hearing is not great, so apologies.
Right,
it may be me.
I'll speak more clearly. No, really, what we're saying is we want to have a much better and much clearer.
What's that better monitoring the data?
Understanding and knowing exactly how many children we're talking about.
Okay.
You know, where there are possibly emergent issues, because I think some of the very challenging, some of the complexities challenging for us. We need to be able to ensure that we have put in place an effective plan, and if we require, and often do multi-agency input to that all the other agencies are aware that there are particular children coming at a certain age who will need particular types of support, and we need to be able to put those in place. We need to be able to identify much earlier if there's going to be challenges with that, whether those are financial challenges or whatever, and to make sure that, as I say, if there's going to be an issue, we identify it early and we deal with it.
If I could come in just with the new regional protocol, we've standardised that across the region, so that should make it easier for us in SPPG and in the department to be able to monitor those returns and to identify areas both of good practice and where there's improvement and be able to act on that quickly, because that's probably the regional inconsistency is one of the challenges that families have faced up to now, and that's part of both the Learning Disability Service Model and the Children with Disabilities Framework is about regional consistency in how families are supported and how children are supported and how young people are supported through their transitions.
Okay, so that's now in place, or that's being put in place, that sort of
protocol is the consultation is completed. We have some final comments made to it, and then we move to the implementation stage.
So while the service model itself, so the adult service model still needs to go out to consultation, the components of transitions are completely replicating what is set out by NICE guidelines. So there will be, of course, consultation feedback about how we actually operationalise that, but good transitions management is already set out in the clinical excellence guidelines. We need to move to the stage of actually implementing that. Data monitoring is a big part of that, ensuring that whether you live in Southern Trust or any of the other four, that you are subject to the same transitions process, and that the right data is being used by the Trust to ensure that adult services, sufficient level of adult services, are waiting for that person when they age into adult services. Additionally, then it needs to flow centrally into the department to ensure that we are providing sufficient resource to meet the level of need that's coming through the system. Now, everything that we talked about, we're focusing a lot on the transition to 18, and it's a very important transition. The transition that keeps parents awake at night is who's going to look after their loved one when when they're not there. It is the same process. We need to use that data consistently throughout how we deliver adult services to ensure that there are meaningful accommodation solutions and shared caring solutions for families as they get to the end of that caring journey together.
I really appreciate that, and thank you for actually addressing that, because that was something that is of concern and has been raised with me as well. If I can just ask one other question, because I know there's probably a lot of people have a lot of questions on this, just around then the parental or caregiver involvement. So how is that been done, but how will it continuously be done, so to make sure that what we're implementing even going forward is working, is delivering for the people it needs to deliver for, that is the young people moving into adulthood and beyond, and then the people who are caring for them, whoever that might be. So how are we going to, the monitoring of that, I suppose, is as important as
will I cover the kind of carers and families piece? Okay, so I suppose in terms of carers and families, what we're setting out via the service model is that we need to recognise the voice of carers better, both in care planning and the delivery of our services. 2, we need to start better meeting the needs that are presented by carers, both in terms of healthcare and social care. The way that we're going about that is a few different pieces, and these all provide conduits then for families to become more actively involved in the care planning for their loved ones. And we always need to balance that against, of course, the views of the person supported as well, in that our own parents probably had very different ideas for us than what we had for ourselves, and it's ensuring that the voice of the person with the learning disability isn't lost in the care planning process. In terms of the service model, we've set out then that there needs to be a single point of contact for families, whether it's healthcare or social care, but families need help in terms of, we need to simplify our complex health and social care system. Families shouldn't be sitting on the phone half a day, getting bounced about by the system to try and find advice and support. We're saying very clearly that trusts need to actively involve families and carers in the planning and decision making around their loved ones across all elements of care and throughout transitions plans. The family should be offered care support assessments. That should inform the development of care support plans. That's about meeting their needs as well as the needs of the person they're supporting. There's actually a big piece just around accessible training, information and support. There's a lot that families just sometimes want a central point of being to know, I suppose, what services are out there, what supports are out there, what guidance and help is out there. Being able to centralise that in a place that's accessible. There's a big piece around short breaks, ensuring that we provide the correct level of service, but actually diversify that service as well. a lot of focus is on residential short breaks, and that is, it's an effective service. But we need to grow our shared care arrangements, our shared lives service, our adult placements, and this is where host families can provide a day to activity type service or a short break to a person with a learning disability. And the other components are around managed budgets as well. I suppose that probably is one of the best tools then, actually, of allowing families to have a much more active role to dictate the type of care, the when, the how, the what that comes through the door. And we're doing a piece of work around managed budgets to try and make those a reality. And that is about taking real control of a budget to set out how are my care needs going to be met and how are the care needs of my loved one going to be met.
Yeah. Thank you. That is really really helpful. I suppose just going forward, I would like us to get an understanding of what the single point of contact looks like and what all that will deal with, because for me that's the dream of every person who comes to me who has a young person or an older person with additional needs. That's their issue. They're saying at the moment, in days gone by, you would have had a social worker attached to almost every person with additional needs, and that was the single point of contact, and we don't have that now, and I'm not sure we're ever going to see that again given the where we are at the minute around social workers. But that would be the ideal. But we do need that single point of contact, because families are doing exactly what you say and they're pulling their hair out, which means by the time they actually get to somebody who can help them, they're already so frustrated that person's getting everything, you know, which isn't where you want to be either. So thank you very much, Chair. Thank you.
Diane?
Sorry.
Yeah, thank you, Chair. So thank you for that. I think it's important that we understand what this might look like in the future. But all of us around the table here will have had the reality of parents who have children, young children with special needs, who don't know where to go next to find out someone that'll help them, or who have a young adult and in the same position. And I do want to actually speak about someone who's transitioning from adult services at 65, 66 into senior, because that I've come across some cases of that recently, and they've been pretty devastating for the families involved. So just sort of a run through life's journey, really, in many ways. So my first question is really around the provision of services for young people, children with additional needs. We have experienced huge confusion and really sort of chaos in getting young children with enough information around them into an appropriate nursery placing. And that seems to me where we've really, those services have broken down, either through the health visitor or through whoever should be providing that information, because I am told that some of these children can't be placed because there's not adequate, they don't have a statement, those statements haven't been through in time, etc., etc. So really my first question is around improved working with across the board between health and education to try to prevent this year-on-year chaos around preschool children who need to go into a special placement at school. And I suppose the other end of that is that, you know, if you have a young person with a disability, they're very well looked after in school until they're 19, and then what? I have had personal friends of mine whose young person with a disability has been offered 2 half mornings in a daycare centre. So while we're talking about how we might look at this in the future, we have to honestly be honest with people and say that the provision in the here and now is very, very sketchy. And much of that caring and responsibility is thrown back on parents 20 years after their child has been born almost. And I just want to try to understand, and for example in England there is legal provision for young people with disabilities right up to the age of 25. Have you looked at that in this context? And if you haven't, if you're not going to introduce it or recommend that it be introduced, why not? Because it seems to me that that would be one of the things that would help to inform what that young person's life would look like, and give them more time to develop and more time to actually be with people who can help them with their understanding. And then I do want to talk to you about that transition at a later stage in life, because I've had some devastating cases around that. So really, that preschool and that change, and why not legislation to protect young people up to the age of 25. I do notice that there is currently a campaign. A mum whose son is Caleb, and she is saying, you know, my child is not at that stage yet, but I'm worried about what he will do. I have no idea whether any of this will be in place, transition workers or anything like that will be in place, but it seems to me that giving them legal cover until the age 25 is quite important.
If I could maybe tackle first your question around information, and just to give you one example, we have produced a service, a resource called Our Journey Through Disability, that was produced with parents, that actually is to help parents who have a child with a disability, written by parents who had a child with a disability, to take literally through the life course and explain a little bit about different professionals and their roles and resources. And that's been something we've developed very much, picking up what you were saying around the often dearth of information, or parents not knowing who to turn to, or possibly wanting to explore some of the things themselves before they approach professionals. In terms of preschool, in partnership with the Department of Education, we run the Fair Play and the Holiday Grant Scheme, which is run through, and what Fair Play does is it provides additional support to daycare providers who want to take a child who has additional needs but may need, for example, extra hours, or may need an extra piece of equipment, or there's something that can be done that would enable that placement to happen. If it didn't happen, it wouldn't. So we do that. So that's kind of, and also in terms of services to support, we also have our Family Support Northern Ireland, which is our online portal for all services.
Right. And all that is fine, and many people working in the field will understand that, but there's clearly a breakdown somewhere. There's clearly a breakdown in communication of children's needs. Otherwise, we wouldn't have a scramble at preschool to have children appropriately placed, or children who, like non-verbal children, being offered places in a mainstream nursery. So there's a breakdown somewhere in the communication, which I think that all the plans in the world for the future won't solve for the here and now, and it's what parents are really, really worried about. And I've never managed to get to the bottom of, you know, why that breakdown has occurred, where the health visitor is not picking up and recommending on further. And I suppose maybe just a further question around that is, you know, I visit a lot of special schools, and they tell me that they have many, many more children. They're always being asked to take more and more children, but they're not offered any more slots from either speech therapists or physiotherapists or occupational therapists. Just sort of, you know, and I know that this is about the planning for the future, but if we're not actually tackling some of these problems, because they're not going away.
So, and we referenced it briefly in our briefing, purely because I think we could probably have another session with you to talk about everything that we're doing in the special educational needs space. But, I mean, certainly, maybe not necessarily a breakdown of communication, but certainly a missed opportunity to use the data that we have to inform long-term planning. You're correct, health visiting is probably one of the most consistent services where we can pick up developmental delay, whether it's gross, fine motor, speech and language, or additional needs. And most children will get most of their health visiting appointments, and by age 2, you would have a fairly good understanding of any form of delay. So, I mean, over 90% of health visiting appointments for that year 2 check have happen. And there is a significant data set that's built up then with that red book that outlines the number of children that have developmental delay and where they've been referred to. We're undertaking a fairly rapid piece of work at the moment with BSO and the Health Intelligence Service to see what we can do to how we can use that data better to make projections about special school admissions and placements. We're working with education in that process, and as I say, not every child that has developmental delay will have a special educational need, but we can at least look over the past number of years to build up some fairly robust assumptions around a level of presenting developmental delay and a special skills placement. That is a very much necessary component then to ensuring we have sufficient places available in special schools. Now, the second component is around the provision of therapeutic supports. This population of children with special educational needs has grown sizably since 2020. I think it's at around 70,000 children, and over 20,000 of those have statements. Historically, we worked across, I think, 38 to 39 special schools. But in response to that growth of population, children are being allocated places now within specialist placements, within mainstream schools. And for some children, that is, it's the right environment, they have access to the curriculum. But in terms of dispersing the health and social care workforce, particularly allied health professionals, we have hit the limit of that workforce being able to work across that number of schools. And for the past number of years, trusts have had to operate a model of clinical prioritisation. Minister Swan in his first term did put, I think, an additional £2 to £3 million into allied health professionals to increase the workforce. But we're really at the point now where this isn't a more money type solution. This is about the reform of the allied health professional model. We need to change how we deliver therapies, because the trajectory very much is that we will continue to place schools or children within mainstream schools. And that means we need to provide therapy in a different way to ensure that those supports, particularly speech and language and OT, are being provided to children with special educational needs.
And the issue of legislation up to the age of 25?
So this was partly the extending the window for transition is certainly something that was reflected in the Children's Services Review. And it is certainly, as part of we've been progressing the work around transitions in the protocol, is something that we are very much still exploring, because you're right, it does provide that longer window for a transition to be managed in a much more phased and managed way. It provides the opportunity, as David was saying, for the person supported to maybe try things that they maybe do like or maybe don't like. The risk is, of course, on the other end, that you simply move the cliff edge from 18 to 25. We're certainly exploring it. Whether that requires legislation to make that happen, we can explore that. But certainly we are cognizant that we maybe need to extend the window for transitions so it is not such a sharp drop or sharp change in a person's life when they become 18.
Okay. So, sorry, it's okay. I just think that, sorry, just to go back on the legislation bit, young people should have rights, and I think if those rights are more clearly defined in legislation, rather than in the hope that trusts will provide equality of service, would improve the ability of those young people to transfer more successfully. We all will around here will have had constituents who are very, very worried about young people and what happens next. And I just think that allowing those young people a longer period to transition and giving them rights while they're doing it, I think, and I have some personal scope in this, but personally I think that it's really important. The other one is around that transfer at 65. I have done some cases in this recently where people who have been in daycare and within learning disability services right through their adulthood suddenly have nothing. And it has been extremely traumatic for elderly carers and extremely traumatic for that person. And I what was the problem of being 65 one day and 65 in a day the next, and having to leave everything you've known for the past 30 years?
I was genuinely surprised when you raised that, because it's been at least 15 years since I was a social worker in the community, and I thought this one had been put to bed a long time ago.
Not at all.
I really did.
Not at all.
It's based on people's needs, and 64 and a bit and 65 isn't a real difference. I mean, it's got to be based on whether the facility can safely meet people's needs. From a human rights perspective and a quality perspective, when trusts have been challenged in this, usually the outcome is a reassessment and the person does continue on in that setting. So that mightn't have been in that case that you're describing, but in my experience, that hard and fast rule of on your 65th birthday you have a leave-in do at your is old world, but obviously that still is continuing on. But I think when trusts are challenged in that, they revisit that decision, usually it changes.
There's a couple of other components to it as well. With currently how stretched day services are, placements will be prioritised for those in the family home, because it helps maintain permanence of the placement. Additionally, then there's a financial tension with this, with trusts in terms of commissioners of service, in terms of care homes. On average, a care homes placement for a person with a learning disability can cost around 200k per annum. And the expectation from trusts at that point then, as a commissioner of a high cost placement, is that meaningful day activity should form part of that package that they are commissioning. It doesn't necessarily always happen, and I've also met with families where exactly they're going through that same issue that you've discussed, where upon moving into a care home, people they've known since special school throughout daycare are suddenly not part of their lives anymore, and the maintenance of friendships
just to be clear, this person wasn't moving into a care home, this person was remaining in the family home, but the likelihood is that sooner or later this will break down because of the lack of placement during the day, and therefore, I suppose, to use a phrase, would be cutting off her nose to spite her face, really, in the middle of it all. I mean, I just think if you're not aware of it, I mean, I don't understand why you're not aware of it. It is happening. Genuinely, it is happening.
I know in the past RKI were involved in these types of discussions too, in terms of registration and status and whether the facility could meet people's needs. And truthfully, I felt this was no longer an issue in the community. It hasn't come to my attention recently, and that's why when you raised it, I thought this one maybe had.
Can I maybe suggest, because we're well over time and we've 3 members still waiting to ask questions. I could suggest we have RKIA coming in the next couple of weeks, and I think maybe potentially it's worth getting a wee bit more detail around specifics to get more information even on that. Because okay, thank you. So we have Alan Robinson.
Thanks, Chair. My question now as the discussion has progressed, probably more a comment now. Diana and I, back last year, had met with the special school, and that principal had expressed her genuine fears and all sorts of trepidation of her pupils that were moving and transitioning from school into day centres. And one of the biggest fears that she had was that they were moving into day centres that were mixed use. There were adults, 60-year-old men in it, no disrespect to any 60-year-old men, but it was a genuine fear that she thought that the safeguarding may not be at its best. How will this model strengthen safeguarding within day centres?
I suppose there's 2 things in that. One is probably the limited choices of transition, and the inevitability then of going into a mixed daycare service. So, I mean, in terms of what we're setting out in the model, we are promoting the expansion of community-based day opportunities. So the type of day activity that's provided to the person, supported, is far more reflective of what they want to do and who they want to do it with. So I suppose that's ensuring there's the availability of services there. I suppose, David, I'll probably pass to you around regulation, but I mean, daycare is a regulated service. It's inspected by the RQIA.
I mean, is the concern about the safety of the young people in a facility in terms of it? I mean, ultimately, well, there are different ways. I mean, there would be a risk assessment completed if there's a specific issue in terms of interfaces or different bits of the building that are shared, I would assume that the facility or the manager would complete some sort of risk assessment around that. It's really hard to know without the real circumstances that you're describing. In my experience, again, children and adults don't tend to mix. If that's is that the experience that you're describing?
Young adults. Yeah, young adults. Young adults. Do you know, who are leaving special schools and then moving into day centres, maybe with a range of older adults. I suppose all facilities which are inspected by RQA will have, they'll have their adult safeguarding procedures that they'll need to adhere to, and in terms of the vetting of the staff and control of who's in and out, and all of the people who are attending will be risk assessed, and there'll be a dynamic, I suppose, attention paid to that, and all the components of making sure the activities are appropriate, the groups that people are in are appropriate, and that there are always a high level of staff, obviously by virtue of the needs of the people who are attending. They would have higher levels of staff, so it's unlikely that people would be on their own for any significant periods of time.
And actually, I suppose there's another component to this as well. So, we will be leaning heavily on community-based day opportunities to provide better outcomes for people. But we do still need to retain daycare, and there will certainly be a piece that we need to consider in cost around the modernisation of daycare, cognizant that some of our services have not seen any significant investment now for a number of decades. And there's a need there to actually improve those environments, because what we are hearing, and this is reported by a number of trusts, is that they are seeing now higher levels of complexity of need coming into daycare, and that's necessitating then higher levels of staff around some of the staff, people supported to meet their needs, but also sometimes lower compatibility between service users, and that turns a centre, let's say that's 20 people, it can turn into 10 people, because you're kind of bubbling, siloing people. So safety, environments, skills mix around people, all components of what we're thinking of in terms of daycare.
Interesting.
Yeah, no, thank you. And I suppose we also have the Adult Protection Bill as well, which we'll be dealing with as well. Nuala, thank you for your patience.
No, you're okay. It is an important issue, and thank you very much for the briefing today. And I just want to focus on two areas, and one is residential and respite care, and the second then is on kind of co-production. And I'll start with the co-production. There are some day centres within our community that are excellent day centres, and they aren't, they're very much run on their own basis. They get some funding from the trusts, and one in particular is Newington Day Centre in my constituency in North Belfast, and quite often they are left really chasing the trusts, just quite regularly for information and for actually giving on promises and commitments that were made, not because of funding issues, but because of reasons that we can't quite get to the bottom of. And I think that creates a lot of uncertainty, but also it breaks down the trust between the trust and the community sector. But it also highlights that there are some within the community that are just run excellently. Some organisations that really are run excellently, and they have fantastic services like Newington. And it's just, how can we, during this, get that kind of co-production model of what any model will look like, based on best practice that might not necessarily come from evidence that the government has, but actually the community has. So that's my first question.
You can take the children's piece.
Sure.
Thank you. Part of the Children's Services Reform Programme is about how trusts and commissioners and the department work more effectively with the community and voluntary sector and with the parents and carers and service users. So we have two work streams. One is about how we more effectively support families together, and then the second one is about the Reimagined Children's Collective.
Well, Newington Day Centre is
adults, is it? Maybe?
Is adults. So,
okay.
So I'll cover the adults piece, and then Ciara's going to cover the children's piece. We've worked very closely with the voluntary and community sector in the work that we have progressed over the past number of years. That is actually built on a fairly significant amount of engagement with the sector, right actually through the COVID response, and the sector very much guided us in terms of the development of guidance, of financial support, and how we interact with housing. We built on that collaboration in terms of developing an uplift package for supported living to ensure that the lowest paid were paid a fair and competitive wage. And that was, I suppose, collaboration, co-production through the lens of responding to a crisis. We've used those, used is probably the wrong word, but we have built in those relationships to involve the sector. The Association for Real Change are a key member of our Task and Finish group, and they've enabled us to engage with over 50 voices in terms of independent sector providers across a huge range of services through nursing and residential, supported living, day activity, short breaks. And earlier this year, we worked with ARC and their providers, and most importantly, the people they support, to deliver an event on meaningful lives and citizenship. And that was everything around how do we enable people to have a meaningful day. And day services are a big part of that, day opportunities, manage budgets. But then we actually started tapping into some cross-cutting issues around transport, which is a huge piece. How do we connect the dots? And benefits as well. There's definitely, and what the voice that was one of the key pieces of feedback that we got from that event back in March, is that there's a reluctance to get involved in day opportunities because potentially that can result in a lower income coming to the person. And we need to address that as a barrier. So very much we will be guided by the people that use our services, and we will continue to. We very much are working very closely with the independent sector, and via the Association for Real Change, we have been sharing iterations of the work that we've been progressing for their feedback, and we will involve them actively in the development of the implementation plan.
And if they have not engaged, might I request or invite you to come along to Newington Day Centre to actually see the fantastic work that they do in the community. And obviously there will be a difference between urban and rural day centres, and we have to recognise that, but where there is fantastic work that can and examples that can be built upon, but hopefully they're part of the engagement of those 50 voices.
Can I just say, I think this is a really important point, because we want to grow the menu services that people have access to, and we want to improve and make that model really get roots in Northern Ireland. We have to engage, but we also have to treat the community development sector as real partners. And I think anybody here from the community development sector would say, actually, you haven't done that in the past. So I think that partnership approach that at times we've really tried to drive forward has been challenging. It's been at the heart of this new piece of work, and we've had really good engagement, and I think that has been a very positive development and help us deliver what we've talked about today, which is a new model that actually works in a more flexible way, that's hopefully better value for men and actually give people a better choice in the community as well. So yeah, partnerships at the heart of it.
And if I could just come in really quick, the Reimagine Children's Collective under the Children's Social Care Reform Board is about learning from community organisations about what works really effectively and how we can scale and spread that across, and what works locally and what has worked here, and how we share that. So,
and one of the other things I want to talk about is the Ivy Centre. Yeah. And whenever the team from the department was at the committee on the 21st of March, there was an acknowledgement that their delayed discharge, the JRs that had to be taken on behalf of and for families and with families, that it shouldn't have happened, and that those instances are regrettable. And this is and one of the outcomes is this in terms of what the model and framework will look like. However, I still I'm not on board 100%. I'm going to be perfectly honest, because of the experience that families had, particularly those within the Ivy Centre, those who have awaited delayed discharge for their loved ones. And it, you can understand if someone might feel waiting until they transition to adults because it's not my problem anymore, and that's how we get them out of it and open the bed space. And it's really really sad that it's come to that. But where are we sitting now with the Ivy Centre? What?
Well, if I can answer that question, in terms of Ivy, in terms of that group of children, they have all bar one have transitioned to out of Ivy. There is one young person still there from the group that you're referring to, and there is a placement available for that young person, and they're transitioning to it, and we expect that to happen over the next month.
And is that transitioning into adult services? So transitioning because it's into adult services, or transitioning because there is provision within the community?
This person is transitioning to resource with adult services. In adult services, sorry, yeah.
And is that the same with the other 4, that it was transitioned
No,
because of
there were
adult
a
services?
range. I mean, there's no doubt that part of the issue with IB related to the fact that in terms of the discharges that there wasn't adequate provision in the community to meet all of the needs of the young people concerned. And I think that's part and parcel of what we were trying to address through the framework. And we were for children with disability. And we're actually saying that we need to look at this in the round. You know, we need to improve the early support to families. And we talked a wee bit about that in terms of what I was saying, in terms of how we try to support children with disability into daycare and with holiday schemes. We've talked as well and developed ideas in terms of how we intensively support families and also how we improve the short breaks. And also in terms of residential, making sure we get a residential model for children with disability rights. So we're trying to take a more comprehensive look at it and recognise that we need to do as much as we can to ensure that children's circumstances don't deteriorate to the point where they need something like IB. And if they need IB, that certainly that they've access to IB, and also that we have services that will support them in their discharge, and that no one should be stuck there, simply up, who their treatment is finished but there's nowhere for them to go. We're also doing, sorry, I'm going to be quickly, I'm conscious of time, just to say that we're doing a lot of work as well in terms of intellectual disability CAMS, and taking IB as part of that. So we're working to improve that service as well.
Look, thank you, and I'll follow up with more questions, I think, because we are
because we were well over
time.
another
I just had to ask one last thing about, because you're here, I'm taking the opportunity, and we're, I don't know, like how many, 6 weeks away, but Muckamore. And so where are we with regards to the residents that are currently in Muckamore before its closure? And I mean, it's obviously not entirely your remit, but at every opportunity I want to raise the opportunity.
I can say something about that, yeah, certainly. I mean, the commitment is for Muckamore to close in June of this year, so clearly where we're at the moment, that's going to be challenging. The Minister and the Department have an undertaking that they'll actually engage with families first in terms of next steps. And I think when that happens, we will write to the Health Committee and just update them as to what that process is going to happen next. But given that there are currently 24 people in Muckamore, and it's very close to the period of June, there's clearly decisions that have to be made and discussions that have to happen.
I mean, it looks like it can't close at that date if there are 24 residents. I feel that it is a bit leaving it until.
And I think that's the discussion and engagement that has to happen.
I think it's. I think just to reiterate, and I understand that this may not be I'm not saying I'm not trying to apportion blame, but when we're coming so close to the end of June, when it was earmarked for closure, and these families and these people have already been through so much, I think there just needs to be that kind of better communication on when a decision needs to be called.
There's going to be further engagement with families in the very, very near future, or for that very reason that you've set out.
And finally, just have Danny online. I know he's having a few technical issues, so his camera's off, but he is there.
Yes, Chair, thank you very much. A lot of the questions that I was going to answer or ask have actually been already detailed through quite a lot of discussions. I'm really heartened by hearing the word meaningful, and helping people live meaningful lives in citizenship, and meaningful day opportunities keeps coming back up again and again. And it's great to hear that there is a recognition about the cliff edge and the transition, and that there is a lot of work going into that at the minute. One of the things I would like to ask, does the department take any account of the provisions of the UNCRPD when taking decisions regarding learning disability, in particular Articles 9 and 19, that's accessibility and living independently, and being included in the community? Did you get me there?
Yeah,
Hello?
I did. It's quite a question to finish with. I suppose this is around, I suppose, accessibility and living independently. I suppose, let's talk about accessibility flows throughout the work that we're doing, because part of what we need to do across the entirety of health and social care is we need to enable a person with a learning disability to use the same health and social care services that we will. To a degree, we cannot create a segregated system. We cannot create a segregated set of health and social care supports for people with learning disabilities. But we still recognise that at times a specialist support is the right service. So a big part of this is around equality of access. There's a big piece that we're doing around healthcare in terms of the review of learning disability nursing and how we use that specialist resource across primary and secondary care so that people with learning disabilities can use the same NHS that we can. In terms of independent living, it's a really challenging space because health and social care have such an important role in independent living, but we don't build houses and we don't provide housing support services. But equally, those two types of housing units and support services won't enable somebody to have a home and live independently without the provision of health and social care. To try and start getting through a lot of challenging issues in that space, we have set up a supported living work stream as part of the Social Care Collaborative Forum, along with the Department for Communities, the Northern Ireland Housing Executive, RQIA, and 7 independent sector providers, all large providers that work in this space. And it really is starting to look at developing a vision for supported living of how we enable a person with a learning disability to access their own home, have choice and control about who they live with, and the role of health and social care to meet their needs. There's some really difficult things to work through in that. We need to understand the best practice around the supported living model. We actually need a definition. It's such a wide type of service. It includes such a diversity of need, diversity of services, diversity of staff. So we need to define it. We need to understand what we're commissioning to date, and actually across all 5 trusts, supported accommodation is the leading area of spend. So health and social care is getting pulled more and more into the accommodation space. So we need to establish good boundaries with housing, and we need to look at what housing provides, what supporting people provide, what we do, and then look at what falls in between, because all of those need to be looked at in the round to support somebody to live independently. That work stream has only just been established. It met for the first time last week, but supported living has been a type of service that has been developing in Northern Ireland now for, I think, well over 20 years. So it's trying to build on what works.
And maybe if I could just say, in terms of the Children with Disability Framework, we particularly use the UNCRC, and particularly Article 3, Best Interest of the Child, Article 5 around parental guidance and a child's evolving capacities, and Article 23 around children with disability as guides throughout the work.
They're fantastic answers, and I'm very glad to see that there is a lot of work starting to be progressed around supported living, and I have been involved in supported living in part of my nurse training years ago, and I see the benefits of it entirely. Just related to the discussion that we have had, are there significant changes between trusts? I know that there has been a bit of a discussion about what's available and struggles that some families are having. So are there significant differences between trusts with regards to delivering services for people with learning disabilities?
In terms of the adult programme of care, we undertook a review of data across health and social care trusts, and as part of that review, we also mapped the services that they provided and commissioned. And what we found is there was 47 service types across trusts, and only 10 of them were consistently delivered across trusts. So, I mean, when I speak to families, they talk about a postcode lottery of services, and that data validates that position. And that is why I suppose the first key aim of the service model is to provide a regionally consistent service for people with learning disabilities, their families and carers.
Absolutely.
And we've also, within children's services, mapped out how the different trusts provide the services as well, as part of a process of agreeing to move towards one consistent model.
Yeah. Danny, sorry. Just wanted to say if we can keep it very brief, because we do really need to move on, but I don't want to. I know you've been waiting patiently.
No problem. Just one last thing, Chair, if you don't mind. Yeah. Nigel had mentioned earlier just about the impact of the European Social Fund cut. Specifically, is there anything you can tell us specifically about the impact that had on opportunities right across Northern Ireland?
Yes, so throughout the concluding phases of the European Social Fund, we worked very closely with the sector, the Department of Finance, Communities and Economy, to prepare for the conclusion of that fund, and then you'll be aware the launch and the potential funding coming from the Shared Prosperity Fund. Now, we worked on the worst case scenario that those that were in receipt of European social funding would not be successful in SPF, and we tried to get an understanding of what that might look like in terms of their organisational sustainability, and we found actually there was a number of organisations that were significantly dependent on that European funding that without replacement would fold fairly shortly after. In order to provide a level of assurance and confidence to those providers that were match funded by trusts, we work with trusts to ensure that the match funding that was provided, which I think accounted for around £5 million. I'll need to double check the figures. But we ensured that the match funding, regardless of the SPF piece, would be in place for those funders rolling into the new year. What that looks like and what we've seen over the past 12 months then is that has impacted the delivery of day opportunities. While SPF did replace a fairly sizable amount of European Social Fund, providers were being paid to do something else. It's a programme that is focused more on getting people into employment rather than the wider types of services that build a journey to employment but are less focused on those targets. So quite simply, those providers have been paid to do something else, and they've had to go back to trusts then to renegotiate what the service they can provide for the lower amount of money. I mean, what it looks like, certainly at an anecdotal level, is if a service was providing a full day type day opportunity service, they may have rolled that back to a half day type service, and that's freed up their afternoons, for example, to focus on their shared prosperity work. But certainly we can see a reduction of funding has resulted in a correlating reduction in service.
Okay. Yeah, certainly, Chair, thank you very much for that extra question. Thank you for your answers.
Thank you, and apologies for having to cut it short. Look, thank you all. As you can see, we actually didn't anticipate that we would have as many questions, but it shows you just how important the issue is. So thank you for your time. It's definitely very useful, and I'm sure we'll see you again, hopefully not too distant future. Thanks very much. Members, we are about a half an hour over time, so I really am going to have to limit questions in the next section if people want to get home tonight. So our next briefing is the workforce policy. We have a briefing paper at page 43, so you will have a sight of that. I'd say we have a maximum of about a half an hour, 40 minutes here, but half an hour is what I'm going to try and aim for, because we have other things to get through before the end of our meeting. So I'll just wait for officials.
Lovely, thank you.
Hello, how are you? Apologies for the delay.
Nice.
You're all very welcome. So in attendance today, members, we have Phil Rogers, Director of Workforce Policy, Peter Barber, Head of the Workforce Development Unit, Stephen Galway, Head of the WPD Business Support Unit, Rodney Redmond, Head of Workforce Strategy, and Chris Wilkinson, Head of Pay and Employment Unit. You're all very welcome, and we really do appreciate your time. I'd say workforce is probably the biggest issue that we've been talking about in this committee, so we're delighted to have you here. We obviously are over time at the minute, so I appreciate if opening remarks are kept to a minimum, because we do have a very detailed briefing paper in front of us, and members will want to ask questions, so if you don't mind.
Yeah, no, look, we'll had prepared a bit of an opening statement, but we'll cut that right back if that's okay. So thank you, Chair, obviously, for the invitation and the opportunity to meet with you in the committee. As I am the Director of Workforce Policy, and I suppose it's widely recognised, as you have indicated, that people who work across health and social care are our system's greatest strength, and our system simply would not run without their skill, dedication and commitment. I suppose in line with principles laid out in Bengoa, transformation of the health and social care workforce is recognised as one of the core components of the successful transformation of health and social care services across Northern Ireland. And to meet the myriad of challenges, I suppose, as you've indicated, facing the workforce, and to underpin transformation of HSC, the Department, working with partners across HSC organisations and the trade union colleagues, have developed and are currently implementing our HSC workforce strategy. And we're currently in the middle of delivering our second HSC strategy implementation plan. And the paper we shared provides the committee then with some detail with respect to the significant progress we think we're making, and also highlights obviously some of the the challenge and some of the further steps which we know need to be taken. I was going to say a little bit more about the strategy, but we'll probably get into that in questioning.
Yeah.
I think it would, however, be remiss if we didn't sort of make a mention of the current sort of pay issues and ongoing industrial action. Obviously, with the return of the executive, we were able to reach a pay agreement with excuse me, Agenda for Change unions, and that's thankfully ended their strike action. But obviously, members will be aware that BMA remain in dispute across their 3 hospital-based committees, and as you know, junior doctors are currently on strike today. Obviously, the department regrets that outcome, and we remain open to and committed to dialogue with all the BMA committees. Just I suppose a little bit on the detail that ministers sought clarity from both the Secretary of State for Health in Westminster and the Finance Minister locally regarding Barnett consequentials resulting from the English consultants deal which was recently announced, and we hope to be in a position to sit down with BMA Consultants Committee shortly to progress pay discussions with them. Junior doctors have said are obviously on strike today, but we remain willing to move quickly to negotiate a new contract with them. We've always been clear that, and the Minister set out indeed on Tuesday in the Assembly debate, that contract reform is the route to pay additionality for junior doctors. We'll also seek to engage with the colleagues on the BMA SAS committee regarding our dispute, but once we have greater clarity on whatever agreement is reached in England and whether there's Barnett consequentials that come alongside that. So, a bit briefer than I intended, but happy to take any questions that you would have, Chair.
Thank you, Phil, and appreciate you cutting that down, because probably we'll go into it in questions anyway. I suppose I'll go first to the pay disputes, and as you referenced there, the junior doctors are currently on strike, and it is, I mean, certainly it's disappointing that an agreement hasn't been able to be reached, and they have made that very clear why. We had them in committee here in the last couple of weeks, and we've made that clear. We obviously had the debate in the chamber this week with the Minister, but I think it's important because, as we said, workforce is the critical issue that's the solution to the many problems that our whole health and social care system are facing. Can you elaborate on, if an agreement was reached, what the impact of that would be then in terms of tackling the workforce issues? So in particular around junior doctors in our hospitals, GP trainees, all of that. So at the minute, what we're hearing very clearly from the Junior Doctors Committee is that until the pay issue is resolved, we're losing doctors. We're losing people who are potential consultants. So can you give us any indication, given you have a workforce strategy, what the impact would be if it goes unresolved, or I suppose given the current figures, if an agreement was reached, how that would positively impact our workforce issues?
Well, obviously, any agreement that we're able to reach will make it more attractive, I suppose, to work in Northern Ireland. It will make it less likely that people will go to other jurisdictions or go to other jobs. I would, though, push back on what some of the claims in terms of the HSC workforce. There was figures published yesterday, the latest HSC workforce stats. Our workforce is growing, and we think that's a great success of our workforce strategy. The workforce is growing. We 16.2% increase between March 2018, when our strategy began, and the figures published yesterday for March 2024. That's an increase that we're seeing across all professional groups. So medical and dental is increasing, nursing is increasing. Our professional and technical professions, those roles are increasing, and that's whole-time equivalent posts. So we're seeing really significant increases across a number of years. So I think sometimes there's a bit of a sort of a run to sort of be maybe a bit more negative than we really should be in terms of some of the successes we're having, in terms of some of the challenges that we're facing. Certainly, we accept that there are challenges in particular areas, that there can be challenges in particular locations, and there are some very hard to fill roles or hard to fill vacancies. But in general, I think the picture is reasonably positive in terms of increasing numbers across the service. But obviously, anything that we can do to improve the situation would be helpful. We are acutely aware, for example, of some of the risks that we face. Sláinte care is obviously one of the biggest risks that we are aware of in terms of consultants. So we keep those things under review. We are anything that we can do that would improve the working conditions or improve the pay of local doctors to make those moves seem less attractive will obviously help. But in general terms, I think we're not as badly off as maybe we sometimes think we are.
And I suppose that leads into my next question, stroke point. But I mean, the briefing the paper does outline a very positive picture in terms of the whole time equivalent staff numbers, and as you've alluded to there, in terms of an increase. But I think something that this committee has highlighted on a number of occasions, given the briefings that we've had from RCN, from junior doctors, from all the different areas of work across the system, is in relation to the actual current vacancy rate. So my understanding is that vacancy rates, the figures that we get, are in relation to those vacancies that are being recruited for, but that's not a true reflection of the real vacancies. And we're hearing that from every sector. So are you able to give us a clearer picture of what that is in reality? Because what's being recruited for doesn't necessarily reflect, for example, and others I'll probably talk about in social work or in nursing. So we may be recruiting for 4 posts in a team, but realistically there's 5 or 6 vacancies. So can you outline the vacancy rates in relation to that? Or maybe it's not figures you have, but it's something that the committee are acutely aware of. Yeah. So I'm just conscious that may look more positive than what it is in reality, and for the people that are actually working in those frontline services and what they're actually dealing with.
Yeah, I'll maybe ask Rodney to come in here afterwards, but the figures that we have in terms of the vacancy rate are the official stats that are produced by our NISRA colleagues. Yes, they do measure the number of posts actively being recruited to, and that will move cyclically throughout the year, just depending on when people are recruiting. It's the best measure that we currently have in terms of vacancies, and we're seeing that come down in the same way as we're seeing the in parallel, or it's not in parallel, it's getting me miles wrong, but as the numbers employed are going up, the vacancy rate is coming down. So as I said earlier, I do accept that there are challenges in particular, whether it's in particular services or particular locations or whatever, but the general picture I think remains quite I wouldn't say, the general picture is one that's improving rather than getting worse.
Okay.
Rodney, do you want to say anything just about the sort of the...
Well, just the issue around the definitions of vacancies. This is one indicator. It's the indicator of recruitment activity. There are other ways of looking at this, which would be funded establishments. As part of our strategy, one of the strands of the workforce strategy is about improving our business intelligence. And we do have a regional information group that is currently looking at other ways in which we can try to assess that sort of measure. So that work is underway, but we wouldn't have that information currently available.
I mean, is it possible that data can be collected then? So, for example, where vacancies are coming up on teams or in hospitals, whatever, surely that's recorded somewhere. If someone leaves the post or retires or whatever, and they're not necessarily being recruited for, but there has to be some data collection around things like that would give us a more accurate reflection of the real level of vacancies.
It is quite a complex issue in reality in terms of the information systems and how the information is collated, and that is being looked into to see is there any way in which we can get a sort of sense of that. But it isn't what I would say, it isn't a straightforward measure as it may seem. Yeah, no, and I appreciate that, and I suppose I'm not underestimating the job of work, but I suppose when we're talking about a growing population, an ageing population, where the demand on all of our services is increasing, and we're potentially not replacing like for like in terms of the workforce, we are going to come into bigger issues down the line if we aren't taking that into consideration when we're planning ahead. So I think that's something that the committee have been very aware of, given the information we've received to date. I've just maybe 1 or 2 more questions very quickly.
We have heard a lot around agency staff and locums and the cost of that. And earlier in our budget briefing with some of your colleagues in the department, we heard that that is a focus in terms of the budget, the incoming budget, whatever that will look like. I suppose then we're very reliant on agency staff and locums to cover those vacancies, which has a massive impact on existing staff and having to then work extra to cover shortages. And, you know, is there work around this to support those staff who are under pressure as a result of that?
Probably a couple of aspects of that question, Chair, if you'll indulge me. In terms of agency, and I think we outline in the paper, we have made significant strides in terms of agency reduction. The Minister, when he was last Minister and before the recent suspension, made a decision to commit the HSE to removing off-contract nursing agency, and we have been progressing that over recent months and years. We are seeing that begin to bear fruit. We've got new contracts in place in terms of the frameworks for agencies to supply into HSE, and we're beginning to see, as I say, those efforts begin to bear fruit. What we've talked about previously in terms of, you know, increasing the number of nurses that we employ directly will have a direct impact on how much we spend on agencies. So we have a cross HSE working group that's led by Neil Coogan from the Western Trust, and that group has been working around agency reduction. And Stephen maybe say a little bit more in terms of some of the numbers, but we certainly look at, we haven't got the figures finalised for this year, but we think we're going to be, and certainly in terms of nursing, we're going to reduce the figure by, we think, about £20 million this year. And social work as well as another area where we've made particular strides in terms of reducing, well, completely ceasing the use of social work agency staff. So again, that's delivered some significant savings as well. The next step, I suppose, for that agency reduction group is around looking at locums then, medical locums, and I think that's the next piece of work that we want to look at, is to try and see if we can replicate some of the success that we've been able to deliver in nursing, and we will be taking action, I suppose, to say, to continue to drive those kind of numbers down, which is maybe what my colleagues earlier were alluding to. So we're taking action, you know, further action this year to try and drive the agency nursing spend down further, but we all want to turn now to look at medical locums spend and see if we can't replicate some of the successes we've had in agency nursing in that space.
Yeah, and I suppose what we'd heard earlier is that that's probably one of the highest spends, so we certainly think that would be useful. Sorry, Stephen.
Certainly, I think the biggest issue probably in terms of the disparity between, you know, our substantive staff and agency staff was the use of the off-contract agency, particularly around nursing. So that's where the first step we've taken is to, along with the trust, is to stop that activity. So with the new framework in place from last May, and then from, I think, August, there was a decision taken to stop all off contracts. So any agency use within health and social care is primarily off a framework at a reduced rate and a capped rate within the service. Social work, all use of agency has ceased. That was from June of last year. So that the first step was to remove off contract, which is the biggest disparity, where you had agency nurses coming in at substantially higher rates of pay. That has ceased now, and then the next step, as Phil says, will be medical and dental and the non-medical. So the non-medical framework will come in hopefully around about October, new framework, and then the medical and dental framework hopefully later this financial year, and they'll take the next steps. And so the focus then will be on off contract, hopefully will have ceased, and then we'll be able to focus on reducing agency itself. And but that, as Phil said, is a multifaceted issue, because you're trying to increase the workforce by substantive staff. You're at the same time trying to reduce your agency use. There's a lot of factors. It's not just a matter of stopping agency work, because there will always be a need for it.
Okay. My last very quickly question, I suppose, is based on, you've said about workforce numbers increasing. We obviously have hopefully negotiations around pay disputes. So is, in terms of retention strategies, then I think that's key to all of this, because if we don't have that in place, we may as well not bother, I suppose, because it's okay recruiting, but if staff aren't staying, then it's a bit of a wasted exercise. So can you give us any detail about what initiatives are being developed beyond, I suppose, nursing and midwifery as well? Because obviously, you know, what we're hearing is that paying conditions is the key to all of this, and that is why we are losing really, really good staff. You know, obviously junior doctors is the one that we're talking about at the minute, but as well, you know, all encompassing, because all of these new people that we're recruiting at the minute, we want to make sure that we're holding on to them.
Yeah. So we have, through our workforce strategy implementation plan, we have a commitment to develop a range of retention strategies for across the different professions. As you will appreciate, the challenges, for example, in nursing will be different from the challenges in, you know, another professional grouping. We have made good progress in terms of a nursing framework and a nursing retention strategy, and we're currently delivering that. And again, that's developed with the CNO and the nursing leaders across HSE. We have plans to work with the other chief professional officers to develop similar strategies for their sectors, or sorry, for their professions. As well as that, really everything that we are doing in the workforce strategy that's maybe not specific to, you know, it's more general rather than specific to, or more strategic rather than specific to individual professions, is around trying to you know, make HSE a more attractive place to work and trying to retain staff. So, as some examples, we have recently, just from April, introduced flexibilities around pensions, which should sort of alleviate some of the taxation concerns, I understand, of particularly sort of senior doctors and things like that as they sort of reach retirement age. We have been doing a lot of work to develop a new occupational health service on a regional basis, so working across the region to try and improve and develop our occupational health offering, again recognising that, you know, keeping people healthy and keeping people well is key to keeping people in work and retaining staff. And I suppose there's just a general point in terms of, you know, coming back to maybe sort of some of my earlier comments of selling HSE as a good place to work. Yes, we do have challenges, and yes, there are some areas which are under severe pressures, but in general, HSE is a rewarding career. There are good opportunities, and there are opportunities for career development in whatever profession you happen to be in. I don't know if anybody else wants to say anything else in terms of retention, Rodney. Is there anything?
Well, I think just to follow on what you're saying there, that whilst there might, you know, quite a lot of the programmes that are being delivered through the workforce strategy would be those that would impact upon retention. We have a piece of work ongoing with the quality of medical education, which Peter will be able to come in on, but we also are currently in the final stages of developing a new staff health and wellbeing framework for all staff. So that's to assist our employers who provide those health and wellbeing services to basically strengthen those services. That framework will help them on how they deliver those health and wellbeing initiatives. We have engaged with about 1,000 members of staff over the last couple of months, and we were coming to the conclusion of that. We hope to launch that in the coming weeks. So that will hopefully strengthen that, which is already quite a substantial provision. But it's identifying what the staff have told us are the key elements of health and wellbeing, and will enable our employers to assess their current offering against that and see in ways in which that can be strengthened. But there's also bits and pieces on the junior doctors.
Sure. Yeah, you mentioned about just conditions as well as pay being a factor that encourages people to come and stay in organisations. So looking specifically at doctors in training, junior doctors, we've really been working on an agenda of measures to improve the quality of the medical education experience. And that can be very practical measures. So, for example, ensuring that doctors are notified, junior doctors are notified of their rotas within 6 weeks, given that those rotas are developed sensitively to their circumstances, etc. And we know that is something that really significantly impacts upon that cohort of junior doctors. And issues as well like protecting educational time, because doctors in training obviously are going through very arduous programs in addition to delivering care, and so carving out protected time for them to be able to focus on that and developing themselves generally. So we've got agreement from all the trusts for this year. Now this is a starting point. I have a minimum of 1 hour per week, which can be aggregated up to an afternoon per month. But the intention is that we progressively over time roll this out and to make Northern Ireland an exemplar in terms of the offer that they make available to people. And there's also issues about working with the employing trusts to improve the facilities, rest and recreation facilities that doctors in training require as they're delivering care for, throughout over the rotas. So these are sort of measures as well, which we think will help. We know it's feedback from the doctors that will make a difference to them and help them to see, as colleagues have mentioned earlier, that HSE is a good employer, it's a good place to work.
No, and I mean, coming from working in the HSE myself, it is a great place to work, but I think at the minute the real difficulty is that it's a chicken and egg. Until we get pay and conditions sorted, everything else will be meaningless. And it's not to take away from the work, I don't mean that in any disrespect at all, but we're not going to have the staff there to actually enjoy the really important things that you've just mentioned.
No, I think that's a very pertinent point you've just made, Chair. As I said earlier, I think things are improving, but there's still a way to go to make things better.
And hopefully, I mean, you mentioned the Barnett consequential, and I'm sorry because I know I'm taking up a lot of time, but it's just as we go on, a chair's prerogative. But just as we go through it, I think this is such a huge issue. But you mentioned the Barnett consequential and the potential around that. So I would hope that there's something there that we can be looking at, particularly around junior doctors and others, that will help to get a resolution, because I do really, and I mean this very, very sincerely, I do really worry about what is ahead if we don't. And I think it's very clear we're probably at a stalemate at the minute, because there's two very different perspectives on what needs to happen and what will happen. So it's very important, and I do hope that a solution can be found. So I am really sorry, members. Nuala.
Thank you, Chair. Thank you very much for your presentation. A lot of my questions will be kind of just supplementary to the Chair's, and also some things that you have said. And just to draw out a few issues, you will be aware that we did bring a motion to the Assembly this week around junior doctors' pay, and I want to touch on that a little bit. But first of all, because it was the last question asked, Peter, you had mentioned about the kind of protected time for educational kind of qualifications, etc. And often, obviously, the sitting exams, studying, etc. Exams that doctors themselves have to pay for and out of their own pocket. But I just wanted to ask, and did the team tell the Junior Doctor Committee that going forward 10% of a working week would be devoted to self-directed professional development, and that this had been agreed by the trusts?
So I think there was, certainly in our discussions that we had with junior doctors, Peter indicated the commitment for this August for the first year is for 1 hour per week, but that will rise, and the ultimate aim is for 20% of time to be protected.
That's right,
Peter?
That's something it would set us as an exemplar.
And obviously that would be staged and phased along the way. In terms of the discussions with your doctors, and I did hold my hands up to this when I spoke to the junior doctors after the meeting, I did misread my notes, and I think I'd said in the meeting that 10% was from this August, when 10% is actually from future years. Okay. So we did hold our hands up to that. That was just a miss.
And have you communicated to the Junior Doctor Committee that was a mistake and that was never going to be 10% from going forward?
Yeah, I'd spoken to the BMA and the officials on that, yeah. Okay,
because if we are talking about negotiations...
I wouldn't say it's still the intention going forward to get to that level.
But from not...
On a staging post to 20%.
Yeah, but you can understand whenever the service at the minute, and especially for junior doctors, is running on goodwill, that whenever the likes of the Junior Doctor Committee are trying to tell their members, look, there's stuff coming down the tracks, stay with us, don't go off, whether it's across the water or to the Republic, there are things that are coming. and then actually it turns out not to be true. It breaks down that trust. And especially when it comes to the pay negotiations, which is my next question, is the contract and pay. Contract negotiations, how long will that take? Because my understanding is it will not take a short time, that it could take years. And that you said in your previous answer to a question that additionality of pay will only go through a reform of the contract, but yet we've also been told by officials and the Health Minister that there is no additionality for pay. And so we also will never have concrete absolute surety that from any Barnett consequentials that it would automatically go to the specific need that has happened in England and Wales. So I just think that there's an absolute breakdown here that and I mean I just don't understand why there's this lack of transparency in what has ultimately been a policy decision to tie up pay and contract, because before there was a health minister it was being said, now that there's a health minister, the health minister said it before the last assembly. So I struggle to understand it, and I'm frustrated, and I'm not a junior doctor.
So I'll maybe bring Chris in here. So in terms of the position of the department in terms of the pay negotiations, we have always been clear that additionality is available, but that's available through contract reform. That's always been our position. I think the Minister outlined very clearly on Tuesday, the consequences of the Minister's not in a position to make a pay award just, for nothing, essentially. He obviously the constraints are well known. The implications and the I suppose the implications for other groups and for other professions, not just within HSC but across the public sector, are quite stark, and the Minister outlined those numbers on Tuesday's debate. In terms of the contract reform discussions, negotiations, talks, whatever we want to call them, we're reasonably confident we can move quite quickly on those. We don't see it lasting years. It may take some time, but we don't see it lasting years. And we have certainly already committed that any agreement that we reach will be backdated to the 1st of April 2024. Chris, is there anything you want to say in terms of the practical next steps?
I suppose where we see it, both the department and BMA recognise that the contract that junior doctors currently hold is badly out of date. The best route that we see to gaining additionality, both from the department's perspective and from the Department of Finance, would be to make that value for money argument and to be able to sit with the BMA and come up with high-level principle proposals as to what that contract could look like, what the doctors will gain out of it, what the service will gain out of it, and then we can, at a very high level, model that and construct a business case to put to our colleagues in the Department of Finance. So that's why we have been keen to try and engage to see what a contract might look like. We can then tease that out slightly and say, well, we think the finance to underpin this could be in the region. That will then form the basis of our business case to submit to the Department of Finance.
And I understand that within negotiations, it's your position, and you don't seem to be budging on it. But the point of backdated to April 2024, then why not move on this additionality
we
now?
Do not have
if
the
it's going to
additionality
be
currently. We would need to construct that value for money business case to submit to the Department of Finance to make a bid for additional funding that we believe would underpin this. We are facing currently a very tight financial position, as I believe our colleagues would have outlined earlier today. So we do not have the funding that we can set aside. We do not have a pot of money that we can say, BMA, this is our negotiating envelope. We would need to do it the other way around. So we need to look at our high-level principles, get a costing exercise done on that, and then see if we can get approval from the Department of Finance to enter into that.
And I understand that with finances, and as does the BMA, as do a lot of the agencies that we have spoken to regarding the current financial situation, because it is a reality. However, issues such as the 6-week rota was discussed 10 years ago. It was first brought up by the Junior Doctor Committee, I think maybe even over 10 years ago. Also in terms of non-contractual conditions have been consistently talked about by the Junior Doctor Committee for years and years, and then they have been reneged on time and again. So something has to give, there has to be something, that a commitment in good faith, especially if there have been mistakes or whatnot, that has to be done. But look, I know we're going to fundamentally disagree on the issue of this, but I will consistently be asking questions, because it is ultimately a policy decision. I do not see it as just a financial decision. It is policy. But my last question is about the SAS doctors' agreement in England, and the BMA there are about to go out on referendum regarding the deal. So have you costed what the implementation of that would be in Northern Ireland?
We have our statisticians and are looking at that currently. We don't have that final costing available yet. We are certainly willing to submit that to the committee when it becomes available. And again, that will be something that we will be keen to explore with the Department of Finance if there are consequentials coming from that.
Okay. Thank you, Diane.
Thank you, Chair. So the other element of this that we hear over and over again is the issue of safe staffing, and how safe staffing and what safe staffing looks like. And I noticed when flicking and reading through this that in paragraph 66 you talk about that originally you had indicated that you would look at safe nurse staffing legislation, and that you have now expanded that to include a definition moving away from safe nurse staffing to safer and effective staffing. Is that a diminution of the guarantee of safe staffing?
No, not at all. In actual fact, it's probably a strengthening of the position. So the original commitment, which came from the last set of industrial action on Agenda for Change side of things, was to take forward legislation for safe staffing around nursing. And before he left in October 22, the Minister took the decision, following a lot of engagement that we had across trade union colleagues and different professions, to actually expand the legislation to cover all professional groups. So that would include AHPs, it would include professional and technical grades, etc., pharmacists, dentists. So that was that decision that was taken at that point, and that's what we have been working with our trade union colleagues on over the interim period. In terms of the content of what will be in safe staffing legislation, we're very close to producing a consultation paper, which we hope to have launched before the summer, which will detail what is in, set out sort of the policy intent behind the legislation. That hasn't really changed, and we work closely with our trade union colleagues in terms of developing both the consultation paper and ultimately developing the legislation once it becomes available. So it really is just a title change, moving from safe staffing to safer and effective staffing. There's nothing more than that in it.
So I will be really interested to see what the consultation says, because it seems to me that what you've done is taken away safe staffing for nursing, broadened the scope of the number of people who are involved in safe staffing. But I want to understand that what you mean by safe staffing in each of those particular areas. And I do understand what you say here, that maybe it's more difficult in some parts of the workforce than others. But I think that, and I'll just very, very briefly, Chair, just give you an example. Recently, I had a staff nurse come to me. She, senior staff nurse, lots of years of experience, and works mainly nights. And she has left some nights as the senior staff nurse in charge to agency nurses, and yet she carries all of the responsibility for safety on the ward during those particular hours, because the agency nurses don't. They have the number equivalent to the number of patients, but they don't have the experience or the commitment or the just even the, I suppose, the knowledge of the ward and the patients. That's all in her. I would suggest that that's not safe staffing. And I do particularly want to know what you mean by safe staffing, and it seems to me that this is kind of meshing it into a whole range of words without giving us any particular definition. So I will look forward to that consultation, because I think that that is really the crux of where we're at, not just with nurses but with doctors and particularly also around the issue of those ancillary services like laboratories and so on that are in hospitals. And you will know in the Southern Trust that we've had a lot of reason to be very, very worried about that particular issue. So I want to know what the I'll wait and see what that consultation involves.
The consultation will provide you with the reassurances you're seeking. I suppose at a very high level, when we talk about safe staffing or safer and effective staffing, what do we mean? We mean that there's the right people with the right skills in the right places doing the right jobs. That's essentially what we're trying to achieve.
And that is a very laudable ambition. I would suggest it's not always what happens. Out of necessity. I'm not saying it's, but
Linda?
Thank you, Chair. A lot of what I was going to ask has already been covered, so I'm not going to go over that again, but I suppose I want to go back a wee bit to where we talked about, and I think it was yourself, Chair, raised the issue around how we actually establish the vacancies, and that's, posts being recruited to. And I understand that this isn't easy, but I think we need to find a way, because if the same logic was applied to PSNI, they've had no vacancies for the last 3 years, and that's not the case, and we know that. So we need to find a way of doing it. I don't have the answers, but PSNI might. Just saying. Let's look across other public bodies. Are there other ways of looking at this and finding it out? I don't, I'm being honest and hold my hands up, I don't have the answers for you, but I'm happy to try and come back with some solutions if I can. But I think we do need to find a way of getting to the bottom of that, because we can't address safe staffing if we don't address what the vacancies are, because we don't know what the safe number of staff is. If we did, then we know how many's vacant. To me, that those two things go hand in hand. So, and I would love to know what the cost of unsafe, inefficient staffing is, because there is a cost to that. We know that. I know that's almost impossible to actually establish, but we know there is a cost. There certainly is a cost financially, but much bigger and much more serious is the cost to the individuals who suffer as a result, and that's both patients and staff. That has an impact. If we want to talk about the well-being of staff, the most important thing that we can do for the well-being of staff is ensure that we make sure that they are working in a safe environment, they're working in a well-staffed environment, and they're working in an environment where they feel safe to deliver what they have to deliver, and where the patients can feel safe to receive that care. So those are more points than questions. I know there aren't easy answers to those, but I'm definitely, we will have to come back to them, because we do need answers to them. But a direct question then is just then in relation to the social workers, the current strike around social workers. So again, that's down to staffing levels, and I'm glad that you're saying, this is going to seem like completely contradictory, I'm glad that you don't have people who are coming in through agency into social work, but what are we doing now to address the real concerns? And the concerns are, they are around that safe staffing level, teams working with maybe 2 or 3 social workers where they should have 10. So there are vacancies there. What are we doing in the very, very, very immediate term to address that? Yeah. And what can we do to support you around that as well? Because, this is a massive issue for all of us.
Yeah, there's probably a couple of things I can say there, just in terms of the social work side of things. Immediately, I think the particular pressures being felt at the minute around children's social work. Now, the chief social worker, Anya Morrison, and her team, to address some of those concerns around vacancy levels, etc., they now run a regional recruitment. So they basically ensure that every social worker who graduates, the aim is every social worker who graduates from a local university will join HSE as their employer of choice, and that approach is having some very good success, and it's helped to drive down. It's helped allow them to make the decision then to move away from agency, the use of agency social work. Separately, and probably into the impact will be felt in the medium term, we were able eventually this year to increase the number of social work undergraduate places.
So 40.
By 40. So from a base of 285, 285, so it'll be additional 40, so it'll be 325 going into social work, undergraduate social work this year. And that's been a sort of a very, well, it's probably not what we need to do in terms of increasing the number of undergraduate places. I think our analysis, and certainly working with Anya and her team, the analysis suggests we probably need at least another 60 per annum, but possibly more. But I think 40 is a reasonable first step towards
60
that.
in addition to the 40 or 60 altogether?
60 altogether was our initial analysis, but I suspect that 60 is probably...
Yeah, it was 60 initially,
should be a bit more.
But we managed to secure additional 40, but in a very challenging financial situation facing the department. I think it was quite a good outcome.
Yeah.
Okay. And I mean, obviously that's the undergraduate places. We have the same issue as regards our social workers potentially heading south. I mean, that's already an issue, because if you live in a border area, starting pay for a social worker in the south is 10,000 more. That's it. You know, there's no getting around that. And we know that children's services is a particular challenge for us. I've asked about that and earlier. That's not just workforce, there are other issues with that, but I will be coming back to that. I just had one other thing and I can't find it now. Look, I don't want to keep you back, but sorry, the 16.2% increase in workforce, and you said that's across all professional groups.
Yeah.
Do we have, I'm not asking you to give me this right now, but even in writing, do we have a breakdown of where those increases are?
So those stats, the most up-to-date statistics were published yesterday, so they'll be available on the website. But just in broad terms, looking March 19 to March 24, so the last 5 years, nursing and midwifery has increased by 16%, and that's 2.2% over the last year, so 23 to 24. Professional and technical, which would include AHPs, 16.7% over the last 5 years, 2.8% in the last year. And medical and dental, which is obviously hospital doctors and dentists, 15.8% over the last 5 years, and 3.2% over the last year. And obviously we have, it's available on the website. We can share the links afterwards. So you have that. As our numbers man,
just to say that that's our official statistics goes back 5 years. The briefing that we provided takes you back to the start of the strategy, which is 6 years. We have a table in your briefing up until the end of December, which has that split. We can have that updated for you to bring you up from the end of December to the end of March. We can certainly provide that. So say that 16.2, that's 2,633 more nurses whole-time equivalent than when we commenced the strategy. It is 787 more medical and dental staff doctors, whole-time equivalent as well, not just head count. But certainly, yes, we can have that provided too.
Yeah, just to say, the paper which we shared last week, which the Minister shared last week, obviously didn't have those most up-to-date stats, which only came out yesterday. So,
okay, I suppose just the last and final point then that I just wanted to come back to is in relation to the junior doctors and the burnout consequences. Just if we can get updates as they are happening, even as that's writing to the committee on what's happening around that. I think there's a real job of work to build relationships there apart from anything else, and just being open and honest. And I know that's not easy, because especially if you don't know what you're dealing with, you don't know what money's coming, but relationships is the most important element of anything, and honesty and openness.
And we wouldn't disagree, and I think we said as much to the BMA when we were last talking to them, that we recognise that over a number of years, perhaps the relationships with BMA have not been as, certainly in terms of those committees, have not been as good as they possibly could have been, and possibly, dare I say it, not even as good as they are with the Agenda for Change unions, where we've worked really hard to sort of build good working relationships. So we recognise that there's a job of work to be done there.
Thank you. Danny, online there. it's 5:05, folks, so.
Thank you, Chair. I'll be as quick as I can. I actually was stunned to hear you there. Now, just to go back to what you said, I understand you said the situation was reasonably positive, and just with regards to that, and that the health service was a good place to work. I can assure you that it is not a good place to work at the minute for nurses, doctors, junior doctors, consultants, midwives that we have heard from week after week at this table. We have people working under intense pressures for extreme long periods of time, delivering unsafe services. Their jobs are affecting their physical and mental health. They're getting burned out. They're walking away from their professions early, heartbroken. Junior doctors are on strike, on picket lines today at the minute, as you were saying that. And I imagine if any of these employees, junior doctors or nurses, are watching this, their mouths will be hanging open. Again, the junior doctors will be on strike again, I think June the 8th or June the 6th, if memory serves, unless this situation is resolved. So, we are in the middle of ongoing industrial action about this. Just going back to something that was said about the junior doctors contract there. Did I hear correctly? You said you can't give them something for nothing. Now I know junior doctors work really, really long hours and work to the bone. Effectively, they do so many extra hours. Do you want them to work less? Can you take that up, please?
I think the point I was making is that we see pay additionality being linked to contract reform. I think there's been a desire or a request, certainly, that we would increase pay without any link to contract reform, and I think that's the point I was trying to make in that respect, perhaps badly.
I think certainly your choice of words, I think were quite surprising, to be honest. But I appreciate your explanation. Thank you. Just to go back to something we had mentioned earlier, the pay award that is being paid for the Agenda for Change nurses that is agreed, can I just get a confirmation off you? We had spoke to the finance team earlier, and they had asked that it was raised with yourselves that the pay is going to be in people's pay packets in June, and that means the 5% uplift backdated to April 2023 and a one-off payment that was agreed as well. Can I just confirm with yourselves that that will be in workers' pay packets in the June pay run?
So the consolidated pay uplift and any back pay associated with that will be in the June pay run. The non-consolidated bonus is coming through in the August pay run. We had discussed that with our trade union colleagues, and they're fully aware of that and are happy. There is an issue often raised with us around people who get big lump sums in 1 month, and that can have a negative impact on benefit. I think there was an original request as part of our negotiations that we try and split it over 3 months. That's more complicated, but doing it this way is possible. Chris, do you want to add anything?
Just logistically, there's a limited number of people within the payroll teams that are all working together to try and get as many pay uplifts done as possible. So certainly the plan at the minute is that all consolidated pay will be done in June. That will include Agenda for Change staff and hospital employed doctors and dentists. So that will all come in June. Simply isn't the capacity then to do the non-consolidated at the same time. It's a bit more complicated. It's pro rata depending on people's working patterns. So there is more involved in that. That's why, and again, to try and mitigate against potential benefits, etc., we had the request to split the payments. So realistically speaking, August is the best date that we can do, with a number of people being off for July on holidays. September would have been probably the next date if we were to do everything at the one time, because the junior doctor rotation takes up a lot of time in August.
Okay. Thank you. At least that will provide some reassurance. I know there was a lot of confusion out there about that. I'm not sure it had been communicated very well. Thank you. I appreciate the work that's being done to try and save money on agencies and locums, and we've talked about it a lot on this committee. It was mentioned earlier that the in-year cost of agency is 373 million. I'm just wondering what would be the saving if you were to move that to a purely bank system. Lots of nurses do what is effectively unpaid overtime by doing bank shifts on top of their contracted hours. Is there anything that you're doing to entice them away from agencies and into the bank to do that instead?
Yeah, so probably a couple of points on that one. So a reduction in the agency spend will not necessarily release finance or the same amount of money, because, as you suggest, what we're trying to do is move people from agency working into either full-time employment, HSE employment, or bank or overtime. So if we reduce the bill by, let's say, 25 million in the year coming in, that doesn't equal 25 million pounds of savings, because some of that 25 million will be spent either on substantive employment costs or on the agency or on bank. We are doing some work to reform the bank, and Stephen might say a little bit about that, just in terms of just reform the bank, as you say, to make it more attractive, to make it a more attractive proposition, because ultimately when we're thinking about staffing and ensuring we have safe levels of staffing on wards or in particular settings, the preference is to have substantive staff. The second option would be overtime or bank, and agency should always be the final choice. So we are doing some work to reform the bank to make it more attractive. Stephen, do you want to?
Yeah, it's reforming the bank is one work stream of a number that are as part of the regional group of looking at agency reduction. So there's been some initial work carried out to see where we could make improvements, and so I think the key aspect is that each trust has its own bank. I think we want to look at the potential for making that a regional bank and moving towards that aspect for delivery of services across health and social care. And that may also include looking at the IT system of being able to access what are the shifts available, when you could have it, when you could get paid. So if you've done a shift for a bank, that you're paid within a week, and you're not hanging on to the end of the month, or it's attached to, because when you're a bank nurse, it's a different payroll number to your normal payroll if you're substantive. So there are different issues. So, but it is a significant piece of work. It's one we are keen to progress, and the trusts are taking it on, and there's a separate project to look at the bank reform.
Okay, thank you. I appreciate that there is some work being done in this area, and certainly it is one that could produce a lot of savings in the future. Thank you, Chair. I know we're pushed for time. I just want to re-emphasise, I would urgently request that you take whatever you can to do to negotiate the contract with the junior doctors. If we lose junior doctors at this stage, we will have no future health service. They are our future consultants or future GPs, and if they leave, if we don't get this right, the health service will suffer incredibly. So thank you for all your time and answers today.
Thanks, Stanley. And just to remind members, we literally have 5 people here, so we just have quorum. If I could ask people to stay, we're almost finished. Alan Chambers.
Yeah, I'd be short. Question. Just a few weeks ago, if memory serves me right, what was said, we had a representative of the consultants here, and he said that he had consulted with maybe 30 or 40 registrars within 2 trust areas, and none of them were expressing any interest in becoming consultants in this jurisdiction. Said the Republic of Ireland was proven to be very attractive for them to go there. The 3 things he referenced, the reasons were pay, terms and conditions, and I think the other one was the opportunity to practice more particular surgical skills. But when I sort of drilled down into it, it really came down to pay. But in terms of terms and conditions between the Republic of Ireland and here in Northern Ireland, do you sort of routinely monitor the terms and conditions that are on offer in the Republic of Ireland? And are there huge differences between there and what's on offer to consultants and registrars here in Northern Ireland?
I suppose routinely monitor is probably stretching it a bit, but we are obviously acutely aware of the risk.
You keep an eye on it.
We keep an eye on it. Yeah, I think we are acutely aware of the risk that the Sláinte Care contract, since its introduction poses for our health and social care system. We have We haven't seen huge numbers depart yet, but as I say, we're acutely aware that that does pose a significant risk. We have, and Rodney will maybe talk a little bit about it, we have been having some discussions with SIB about doing a bit of work to try and understand the overall package and the overall relative attractiveness of the two jurisdictions, looking beyond the headline differential on pay, which, as you're aware, is very stark and quite acute. So we have begun a little bit of work with SIB on that, just to try and get a better understanding of what the relative positions are, so that then we can then take whatever action we feel necessary to respond, to sort of, I suppose, rebalance it in closer to our favour. Rodney, do you want to?
Yeah, no, I haven't really got a great deal to add. That work's still very much in its infancy, but that will essentially be looking at in the round the difference between the two jurisdictions, not just in pay and so forth. So yes, we will hopefully be progressing that in the coming months. Yeah.
And just a wider point, I mean, this is a very mobile, potentially mobile workforce, part of the workforce, so we're actually engaging with GMC, who is the regulator, to understand from their statistics what the patterns and movements are of consultants, and then to try to pick underneath that really what are the factors and reasons affecting. First of all, is to try to get a handle on the facts.
Thank you.
Okay.
Thank you.
Okay, look, thank you all. And again, I did allocate it half an hour, but I do appreciate the importance of the issue. And I suppose, as I said, it's underpinning every discussion that we have. But I do hope that we can make strides. And hopefully, I mean, I know we're sitting on a very difficult budgetary position. In the coming weeks and months. But I think, just to reiterate the point, particularly around the junior doctors, the social workers, we hope that we can get resolutions on them very, very quickly, because we're going to be in a much worse position if we don't, I think.
And you know, I would echo those sentiments. I think we would really hope that we can move forward to reach resolution on the various disputes at the minute. And I suppose the last point I would make is we probably could have had a session on any one of those individual issues that we reached. You know, it is a very broad, very wide issue in terms of workforce, and I think, as you said at the outset, a lot of everything does seem to come back to workforce on a number of occasions.
I think if we can get the workforce right, and I said it in the chamber this week, we heard it from the representatives for the SAS doctors. Without the workforce, we're just going to have empty buildings. So I'll leave it at that. But listen, thank you so much. We really do appreciate all your time and the work putting into giving us today. So safe home, everyone. Okay, members, thank you. We're hanging on by a thread here. Thanks for the small number we've left. We'll move very quickly through the last couple of items. I'll move you to correspondence. I've nothing specific to raise on any of the items on the correspondence list. If anyone else wishes to highlight anything, or we're happy to agree as detailed on the
Agreed.
Happy enough. The suggested action, sorry, I should have said for the items listed. Item number 9 in the forward work programme and the committee priorities at page 96, 98 of your pack. Just to note, the meeting with the Oireachtas Health Committee on the 17th of June. Just obviously conscious it clashes with plenary, but if we can get a good attendance at that, I think it's a very, very worthwhile visit to the Queen's Cancer Research Centre with the committee in the morning time, and then we will have an informal meeting with the Oireachtas Committee here in Parliament Buildings from 1 o'clock on that day. We also have an invite from VOIPEC, but we've discussed it informally at the start of the session, because obviously there may be changes to committee forward work programme towards the end of that. Are members content then to note the briefings as set out in the programme in your pack?
Agreed.
Any other business? No. And just the next meeting will be next Thursday, 30th of May at 2 p.m. and the pack will be issued tomorrow on account of the bank holiday on Monday. So thank you all, and just thank staff as well, because